We may kickstart the afternoon, as we are running slightly later than later. And in doing so, I'm really pleased to open the next panel and the next session, which is on breaking silos and bridging borders. And in doing so, I'd like to introduce a colleague and a friend in our activities. So Dr. Andy Keller, who is the president and chief executive of the Meadows Mental Health Policy Institute in Texas. So, Andy, the floor is yours.
Well, hi, everybody. It's great to be here today. What a wonderful morning. And is this the machine I use to advance things? And do I push this button? And do things happen? Well, hi, everybody. Thanks for being here. What an amazing amount of information and excitement to pack into one day, and so many fantastic ideas are being discussed. And I think just from the morning, this has been wonderfully successful. We're going to try to become very practical and laser focused in our talk about mental health, because for the mental health component of the brain, we're experiencing a crisis that actually has been going on. Really, it's been going on for a long time. It's been getting particularly bad in the last 10 years, and it's gotten really bad since the pandemic. So, Casey, I think, why don't we let the panel, why don't y'all come up? Or actually, we shouldn't, because of the video. Yeah, okay. I'm not very good with logistics. That's why I went into mental health, because I actually just have to talk and not actually do anything real in the world. So I'm going to talk from the perspective of the Institute. And so our Institute is based in Texas. And our vision is really to be at the intersection of policy and programs. What are the policies that promote effective programs, and what are the effective programs and interventions that policymakers should be focused on? And we really try and do that by being at the local level, at the state level, with other states in the United States, and at the national and global level, because we're all dealing with the same set of brain issues, and none of us have enough resources on our own, and none of us are going to be able to address this crisis on our own. And I just say this for purpose, like in Texas, we've been able to increase our baseline mental health funding by about $5 billion over the last several years, which, I just say that because, like, Texas, y'all. I mean, like, we're spending more money on the brain in Texas than for mental health. And so if we're caring about mental health in Texas, that means we can pretty much care about mental health everywhere, because that's not the image we typically project from Texas. We also have been collaborating really well with people in Congress. And I think there's even though things are more polarized in the United States than they have been recently, I mean, if you look back across our history, there have been worse times. But at a rhetorical level, it's pretty bad. But still, people are coming together to set priorities and to do things collaboratively. And John Cornyn and Senator Murphy from Connecticut came together last summer for the Bipartisan Safer Communities Act with $10 billion in funding nationally. So we're seeing really historic investments in the mental health services side, and also some increasing investment in the research side. And our friends and colleagues across the country are doing similar things in their state. Governor Newsom with the $4 billion Children's Initiative. The initiative here and the focus in the city of New York puts children and youth at the top. So we see a lot of synergy across these different initiatives. And I think a lot of them begin with this drawing that, healthcare as a whole, for the parts of healthcare that are working not great, but they're working good enough for year-over-year mortality and morbidity to be decreasing. Things like cancer, diseases like heart disease, where we see year-over-year improvements. We have a relatively organized system that begins with primary care that's all about early detection. Whereas on this side of the equation for mental health care, we really wait until there's a crisis, until either you notice that you're sick or someone else does. And that's what we used to do for heart disease. My grandfather in 1976 had his heart disease diagnosed when, I guess, he woke up from his coma, because he died. He was dead for about 4 minutes with his heart attack. They resuscitated him. When we woke up, they let him know he had heart disease. And they sent him home with egg beaters, which, low calorie, low cholesterol diet. My heart disease risk was diagnosed when I was 35. And for the last 22 years, I've been harangued about my diet and my statin and all that kind of stuff, which probably means I'm not going to have a heart attack like he did, hopefully. So that's what's happened on that side. But we wait until you notice. And if you don't get care until you notice you're sick, or until someone around you notices you're sick, that's not going to work out so well. 10 to 11 years in the United States is the delay between when symptoms begin, clinically relevant symptoms begin that could be diagnosed, to when people receive care. And that has not really changed. It's been pretty constant for the last decade. And we're not unique. This is not a United States problem. It's a human problem. The other thing is these are illnesses of childhood. So these are me. That's me. So that's little baby Andy. And little baby Andy had anxiety. Probably, I don't know if I had anxiety when I was that age, but but not long after that, because when I was 20 months old, I got attacked by our dog, who I don't think meant to do it, but he did. And so I definitely had some post-traumatic symptoms from that. I didn't really know what that was as a kid when I would look at my hand, and I didn't think it was real. And I wondered if it was really part of my body because I was, depersonalizing there a little bit. Wasn't too freaked out about it because my mom didn't seem too concerned. And so I went on with my life. I figured that's what happens to everybody. They think parts of their body aren't real. So living with that anxiety disorder, even when I went to prom, that's what you wore to prom when I was 18, still had the anxiety disorder, still had not received treatment. I wouldn't receive treatment until I was 22 years old. And the treatment was really helpful that I got when I was 22 years old. But that's also a really important age, because if we were to actually use the U.S. Prevention Task Force guidelines, I would have been had my anxiety detected at age 8, because that's what we recommend right now that pediatricians screen children for in the United States. Almost no children are being screened when they're age 8. But the cool thing is if you detect anxiety at age 8, then you're watching little Andy grow up, and you're talking to him each year if he's in primary care. And when little Andy gets to be 18, when little Andy's anxiety may shift to being a psychosis, then my family's going to be ready to confront that and have more resources and be able to diagnose that illness when it manifests itself later in my life. Because that's typically when psychoses become evident, age 15 to 25. And the reason that last picture there is of a younger Andy, that's Andy age 49, is right now that's the age I would have died in Texas on average if I'd had a severe mental illness like bipolar disorder or a psychosis. So that's why early intervention and early detection is so critical. So we're going to talk about some fancy things. We're going to have some fancy people talk. We're going to have some fancy friends in the European Union talk. And by fancy, I mean cool. But the bottom line are a couple things I really think that if we could just catalyze and focus on these simple, practical things, it could really give us a concrete and specific vision as we try to do more with these resources that are coming our way. So one of those things, I'm just going to mention two, and then I'm going to introduce the EU Commissioner to talk about the EU's mental health initiative, is something we're doing in Texas, which is scaling telehealth responsibly to schools. So we started an initiative in 2019 after we'd had some school shootings, one in particular at Santa Fe High School in 2018. We'd had a hurricane that impacted about 2 million students and caused a lot of PTSD, Hurricane Harvey along the Gulf Coast. And what we realized was that we weren't doing enough to reach students and teachers in need. And we could most easily connect people with telehealth. And if we could create a system where people could get an urgent telehealth appointment same day from one of our 12 medical schools, because that's where most of our child psychiatrists and child specialists were, that would at least help people prevent the worst outcomes and potentially link to other services. We had that in place in late 2020 for about 40% of our 5 million students. And then last summer, summer before last of 2022, when we had the horrible incident at Uvalde High School, Uvalde Elementary School, where we had those young children lose their lives, we realized that we really needed to take this statewide, because while that individual was in a very violent stage and there was a lot of issues that contributed to that shooting, 2 years before that, he walked into a school with cuts all over his face, with just classic agitated depression signs that if we had recognized, we could have helped him with. It's a depression we treat every day in Texas, and we missed it, and a horrible tragedy grew out of that. And I'm not saying that's the only reason, but it certainly was a reason. So this telehealth network, by the end of this school year, is going to be scaled up to reach 4.8 of our 5.2 million students in Texas. And it's not fancy, y'all. It's just a matter of having a memorandum of understanding that links the largest aggregate of mental health providers in Texas, which is in our medical schools, with our schools. And now that pipeline's there, innovators, researchers, others, we have 2 research networks in this network now that have over 3,000 children involved in longitudinal studies of depression in one, and another 3,000 children involved in longitudinal studies of the effects of trauma. And that's allowing us to really begin to scale not just innovation, but also understanding. So that's something that's not hard to do. And it's the kind of thing I think we should be talking about. Another one we're doing is partnering with the Harbor School of Global and Social Medicine, Dr. Vikram Patel, who's now the chair of that program, with his Empower program. And Vikram's Empower program is pretty cool. What he did was they developed it in India, and they worked with community health workers and trained them in behavioral activation, which is an evidence-based intervention for depression. It works, and lay people can learn it. And those lay people can be maximally effective if they have a digital platform that allows them to do evidence-based screening, so they can kind of monitor how bad symptoms are and be able to link then to health professionals if something more than a lay intervention is necessary. But a lot of the lower to mid-level depression, even mid-level depression, was able to be mitigated by the community health workers' interventions. So we basically imported a treatment approach from India into the United States, and we, in Texas, are the first place scaling the empowerment program to our folks who live there. First had to translate it from Hindi into English. Hindi into English. And now we've got it translated in English, and we're deploying it in Central Texas. We're working now on doing a cultural translation of it, not into Spanish, which there's a lot more cultural issues and idiomatic issues we need to deal with, including the really important issue that people who speak Spanish in Texas are within a health system that's predominantly English speaking. So in addition to having to do behavioral activation, we also have to do navigation of somebody who's getting their health care in a language that isn't the main one they speak. And it's a fantastic intervention, and we're talking to Kana and others about potentially exporting that to other countries and having this kind of global impact that's very much in line with the Lancet World Psychiatric Association's Commission on Depression recommendations that were released last year. So these are really practical things, bringing lay people in, building the workforce, and they're the kinds of things that I think if we could really focus on, we could see rapid wins, rapid shifts, but it's going to take a lot of effort to do that because it's hard and there's a lot of friction, and doing simple things can be very hard when there's this much friction. So I'm going to pause there, and I'm going to let a video start. And the video we're going to see is from Commissioner Stella Kyriakides, who was not able to be here today in person, but recorded this overview of several things going on across the Atlantic in the European Union, including their new mental health initiative. So if you could just give attention to the video, and then after that, we'll go to our panel.
Ladies and gentlemen, I would like to begin by thanking the European Brain Council for inviting me to address this very important conference today. Healthy brain and a healthy mind are central to good mental health. And this is why finding long-lasting solutions to protect and promote them is so important. As we all know, mental health issues can affect everyone from all walks of life in many different ways. In the EU, millions of citizens were already experiencing mental health challenges before the pandemic. The impact of COVID-19, together with the daily reality of the war in Ukraine and the high cost of living, have served to make a difficult situation even worse. We must make addressing the issues around mental health our top priority. The future health of our citizens and societies depends on that. To that end, in June, we presented a new comprehensive approach to mental health in the EU. It is a cornerstone of the strong European Health Union we are building and is based on one clear message: that mental health matters. Our citizens must know that it is okay not to be okay. They should be encouraged to seek help and supported when they need it. Our comprehensive approach puts forward 20 flagship actions covering a broad spectrum of issues. And these range from better mental health, promotion, prevention and intervention, access to treatment and care, quality of life, gathering of data and training of health professionals. And all this is backed by over 1.2 billion in EU funding. Our blueprint for action will help support the mental health of the most vulnerable in society, including children, the elderly, cancer survivors, young people, and people affected by conflict. Beyond the comprehensive approach itself, our EU initiative on non-communicable diseases, called Healthier Together, is helping our member states and stakeholders pool resources and share best practices to reduce the burden of these diseases. And mental health and neurological disorders form a priority strand of this initiative. On the research side, brain research remains a long-standing health priority, and that is why the EU is investing heavily in it through Horizon 2020, Horizon Europe programs, and through better prevention via the EU for Health program. Ladies and gentlemen, our actions will only be effective if we work together at the European and international levels to step up our collaboration and strive to make a real difference for everyone. It means forging strong partnerships with stakeholders such as the European Brain Council and international fora such as the United Nations. And the EU will always play its part in this endeavour. I look forward to pursuing our ties of collaboration and support. Together, we can put the physical and mental health of our citizens front and centre. Together, we can deliver for them. Thank you.
Well, the details of that initiative are very aligned with the early intervention and youth focus and comprehensive integration focus that I was talking about. And now we're going to have a wonderful panel come up here and talk about the implications of this really for the global community of high, low, and middle income countries and how we can really come together to address this. So let me introduce the panelists. Leading our discussion is going to be Casey Kelly, who's our Chief Innovation Officer at the Meadows Institute. So Casey, come on up and grab your choice of chair. She's being joined by Dr. Kara Altimus. Kara is the Senior Director at the Center for Strategic Philanthropy at the Milken Institute, and is great to have you here, Kara. Danish Munir, founding partner at Gray Matter, will be joining the panel as well, a wonderful VC firm that we're thrilled to partner with for policy work. And Kana Inamoto, Director of Brain Health at the McKinsey Health Institute. So welcome all. I'm going to duck across in front of you and sit over there and let you carry on.
Good afternoon. My name is Casey Kelly. Thank you, Andy, for kicking off this panel. I am delighted to be here with some of my favorite colleagues. You know, at the Meadows Institute, we really do believe that the only way to have impactful innovation is through collaboration. And I was also thrilled to hear almost every session this morning talk about breaking down silos and bridging borders. Because as we drive our innovation agenda, that's really how we think about it and how we're operationalizing it. Our goal is to create an ecosystem of innovation in Texas that can be scaled. And I often describe my job as chief translator or as being an exporter or importer of new and novel things that are driving better outcomes in mental health care. And so today, I'd really like to kick us off with a question for Kana. And Kana, I'd love to hear you talk about your experience and what international cross-collaboration looks like.
Thanks, Casey. It's interesting because as I thought about this question, I thought there's kind of the fantasy of what I would like to see and what we've seen in other sectors, and then kind of the more modest reality of what we're doing today, which is still extremely exciting. So, we at McKinsey Health Institute, we're a nonprofit generating entity within our firm that is committed to extending, adding life to years and years to life. And a major pillar of that is brain health. We are partnering with both public sector and private sector entities like WHO and World Bank and COCODO and Healthy Brains Global Initiative. And in that, we've heard some really interesting concerns raised or issues raised about, well, how do we know what to invest in? How do we know what works? Some of these things seem unclear. And so what we've identified as a major need is to create these international and cross-sector collaborations that have a clear definition of impact. Right, that have diversified funding sources, that are focused on making funding more efficient. Right, so we're braiding and pooling funds so that we can make it easier for those who are then ultimately trying to be impacted. I think we need to be focused on outcomes. Right, so not just paying for people to do things, but paying for people to produce outcomes that have impact on real lives. And I think the fifth pillar that we sometimes miss is really listening to the voices of people who are affected, right? Like listening to people with lived and living experiences, which I haven't necessarily heard as much of this morning, but I think that is really central to what we're doing. And so as we look at having impact in localities as well as in nations, I think that is something that we're centering our work on. And then ultimately, I'd love to see something like CEPI, like Gaia, like a global fund, where we could really be having that at-scale impact with all sectors engaged.
And are there a couple of things that you think that we can build upon related to the workforce expansion needs that Andy referenced?
So, I am a huge fan of task sharing. I think that is going to be one of the crucial solutions in addition to technology. I think we really need to look at how do we have the super specialists that we have in our field really practicing at the top of their licenses, and then engaging not only sort of non-specialist healthcare providers, so the primary care folks, the nurses, but also lay people who are in communities, who understand the local cultures, who speak the languages, both literally and metaphorically, of the people who need services most, because that's how we're going to cross over those inequities that we see for people who don't live in the big cities, who don't have access to, one of the few neurologists or psychiatrists in their countries or their communities.
Yeah, I love that. I mean, Andy mentioned the Empower project that we're working on, importing in Texas. But we've also been learning about another program out of Johns Hopkins called CETA. There's a program out of Columbia called Engage that really is sort of building momentum around using data-driven, outcomes-driven protocols that people with bachelor's degrees, associate's degrees, or no degrees can actually deploy.
Or friendship bench, right? Grandmothers who have a status in their communities that people trust, and who can learn, components of CBT and deliver them to deliver outcomes for the folks with whom they live and that they care about in their communities.
Great. So I'd like to turn now to Kara, who has been really instrumental and a driving force behind uniting a range of stakeholders and investors behind a common mission of addressing bipolar disorder. And Kara, can you tell us a little bit about some of the lessons that you're learning about bridging those silos and the work that you're doing?
Thank you. So as Casey alluded to, a year ago last week, we launched BD Squared, which is Breakthrough Discoveries for Thriving with Bipolar Disorder. And its mission is to deepen the science and improve care for people living with bipolar. As we launched into planning for that, which was more than a year ago, we realized really rapidly that we needed to bring a lot of different kinds of stakeholders to the table. We needed to deepen the science, that's researchers. We needed to improve care, that was clinicians. We needed an agenda that actually spoke to and addressed the needs that people experienced, those people living with bipolar disorder. And to make all of this happen, you have to engage funders. And so a big part of BD Squared's success is actually creating space and shared development across a number of stakeholders and doing that iteratively and in a developed standpoint. And so I think thing one for developing collaboration and breaking down barriers is making sure that you're routinely assessing and bringing the right people to the table, and asking yourself, do I have the right people, and how is the world changing, and creating space for a lot of different ideas while still driving towards a North Star. The other thing I think has been really important in our first year has been, particularly in collaboration, is that collaboration starts with our funders. If you want researchers or clinicians or communities to collaborate, asking those individuals to do that hard work when the funding structures don't align is not a very efficient means to do it. Whereas if you bring the funders together and identify points that collaboration is possible, or do the work of aligning expectations and the direction, you can actually get a lot further, a lot faster. Additionally, you can bring a lot more dollars to the table and direct them in the same direction. And so you're able to move a lot further faster. The last thing, and I actually was sharing this over lunch, I think in mental health and kind of the biomedical space generally, we pit science against care improvements or access. And we have to stop doing that. Those are intimately related. And so collaboration globally is not just about actually bringing any one sector together. It's actually about believing and creating the space for clinical and scientific innovation to happen together simultaneously, and that requires investment and infrastructure as well as people. And so to just summarize all of it, I think it's about alignment of funders, investment in infrastructure, and the belief, the knowledge, knowing that we have to bring the science and the care together in the same initiatives, and that will drive progress, meaningful progress, a lot faster.
And Danish, you've been at the forefront of technology and the investment community, and now you're starting to dip your toe into the policy community. Can you share a little bit about what's motivating you and Grey Matter to try to bridge that additional stakeholder group?
Absolutely. But before I do that, I want to just thank you all for putting this together. Every time I'm around these ladies, I walk away smarter. And so it's great to be here. So for context for that question, Casey, I spent 10 years building one of the first mental health companies in this country, focused on SMI Medicaid populations. And we were able to scale that to be in 35 states, serving 250,000 patients a year. And so I come from like the founder perspective and the builder perspective. And I think that community is one that often is underrepresented in these conversations, because at the end of the day, once the science is developed, it's those communities that are helping take that to the last mile, right? Once the science is developed, once the policy is set in place, it's these entrepreneurial communities that get this in the hands of people who actually use these innovations. And what I found is that there's a big chasm in healthcare where the entrepreneurs are on one side, and the capital is in Silicon Valley and in New York and in some places, and now increasingly in Texas. But the researchers and the academics are not talking to each other. And I experienced this most viscerally in my time when I was at United Health, after our company was acquired, where I would see pitch after pitch after pitch from founders asking the same questions that could have been so easily addressed if they had just had been surrounded by the right support from the research community, from the policy community. And so really Grey Matter was born out of that, seeing that gap in that connectivity between those communities and saying, how can we make the next 10 years of innovation in the space go faster than the last 10 years did? And to do that, it is essential to have these communities coming together, having kind of doing that gardening work required to create a cross-pollination of ideas, because it'll take someone who's seeing where the corners are on the policy side and what's about to come down the legislative pathways, sitting with somebody who really understands technology well and can leverage that to meet that need that is society's just starting to get ready to serve. And that's where Grey Matter sits at that intersection.
Great. And you've all sort of demonstrated your ability to bridge stakeholder groups and to break down borders to drive innovation in mental and brain health. I'm wondering if you could now spend a few minutes sharing with the audience what you wish someone would have told you 10 years ago. Like, what are some lessons learned and even some failures that you might have experienced that if you were someone in the audience, you would want to hear about?
I'm happy to start. We made a lot of mistakes. I think when it comes specifically to collaboration, the biggest mistake and sort of the biggest learning that we had was just being able to understand the incentive systems at play for various stakeholder groups. And so whether you're working with regional governments, local city governments, at the national level, with different agencies, with the health insurance companies and payers in this country specifically, which is a unique context to this country, understanding the incentives is critical to taking any innovation and being able to advance it. There are I see so many brilliant scientists and researchers working on things that sound perfect in the lab, but they are somewhat disconnected from the incentives at play in the industry. And even if they're scientifically successful and they make the technological progress they want to make, probably will never reach consumers because they haven't been informed by those constraints early enough. And so understanding, at the very onset of what objectives being achieved, who will it touch along the way in terms of stakeholders and what their incentives are, so you can maneuver appropriately from day one is critical.
So it's not just what is the solution or what is the innovation, but it's the pathway to get to it.
Absolutely.
Connor, you want to say something?
Yes. So I think if I was going to go back 10 years, the first thing I would wish is that someone said, get in front of the prescription drug problem. That being said, I think a lot of progress has been made on that front, and I'm grateful for that. 10 years ago, I was leading SAMHSA, or I was at SAMHSA, and sitting on top of the largest mental health and substance use agency within the United States, and we were almost entirely focused on the public sector system. And what I wish someone had told me was that we are never going to scale what works. We are never going to get the investment that we need to really address mental health and substance use in this country without bringing in the private sector.
I love that. I also was working in the public sector 10 years ago, and I wish someone would have opened my eye to the fact that the private sector wasn't evil. They were actually going to be key partners. And one of the things that we're working really hard on now at Meadows is building upon the success that we've had to weave together philanthropic dollars and government dollars, and now weave in that third thread of private sector investment and industry dollars. Because if we're going to tackle the complex problems that we have in this country and around the world, we have to leverage all of our resources and all of our tools. Kara, I'll just give you a chance to offer any lesson learned in your vast experience.
Related, I think one of the things that strikes me the most is time, and how time intersects with the progress that we make, and that in any moment, I always feel like it should be so fast to get to the next moment, and it has taken so long to get here. I'm very impatient. But when I reflect on all there is to do, I think about the proverb of if you want to go fast, go alone, and if you want to go far, go together, which implied in that is that it's worth taking the extra time to bring more people on board to go further.
Thank you. So I'm going to just shift a little bit. One of the other than workforce, one of the other points that Andy made in his visioning was that we've got to get to our youth sooner. And we've got to figure out ways to meet them where they are. And as we think about that point on a global lens and the diversity of communities around the world, how can we make sure we're fostering collaboration to be inclusive and increase equitable access to care?
I'll start. The point was made earlier in the day that there was a real need to have a model of centers of excellence around the globe, and that we have to have expertise around the world to do that. And implied, but I think really important to highlight, is that we have to be networking those centers for excellence so that they are sharing findings, common practice, data across the board. And so I think as we are looking at how do we address mental health, particularly in youth, but really anywhere, we have to be thinking about how do we raise the sea across, and how do we connect to bring the best in a much more to connect ideas in real time as best we can, and think about how do we use people and infrastructure as a way to do that.
Kind
of. But just to pile on to that, I think someone referenced, and we saw the IHME data earlier, which are fantastic, which show the burden of brain health conditions, starting much earlier than chronic health conditions, other physical health conditions. And so I think we need to make the case, we want to reach our youth. Frankly, our youth already know that these are issues, right? Like, we do Gen Z surveying globally, 26 countries, 40,000 people. Like, we know that, like, the young people will tell us we are suffering for our brain health. sometimes social media is good, sometimes social media is bad. Sometimes our spiritual health is good, sometimes it's bad. But it is one of their top priorities. But countries also need to invest there, right? So we need to use the data that show that if we can intervene earlier, right? Like half of the symptoms start by age 14, 3/4 by age 24. If we can get in there, we can mitigate some of that. We can prevent, otherwise serious conditions from becoming brittle. We can help young people develop the resilience that they need to become economically active and to stay economically active throughout their lifespan. And I think there is great benefit not only to the people in the communities, but also to nations and our economy. And so I think we need to make that case and then listen to our young people and let them guide us to where they want the most support and help.
Maybe I'll add one more to that. So I think this is less in the treatment side and perhaps more on the prevention side. And I know there's a lot of debate and a lot of data out there around the role that technology or the internet plays in this. But I started my career at Microsoft, where we were first. This is right around the time when the iPhone was brand new and Facebook was just reaching high school. So we were studying these phenomena from a user perspective and seeing how young people were adopting these technologies. And I think most of us, the debate and the data aside, I think if any of us get a weekend where we drop our devices and just plug into nature for 2 or 3 days, we come back and we feel the difference and we know what these things are doing to us. So I don't think that we need to wait for the data to start acting. I don't think we can be conclusive yet, but I think we can still start. There's things we can start doing, and that's an area of collaboration where countries developing standards that can be global, because technology is developed everywhere, and we need frameworks that are international to support what is safe and healthy for our children is a really strong starting place. And there's some work starting to happen but I'd like to see more there.
Yeah, I was just going to comment that it's been awesome, frankly, to see the youth advocacy groups stepping up to really take a leadership and a voice in responsible technology when it comes to brain health. And there are many days when I think like that coalition is going to actually help us transcend some of the barriers that we've been struggling with for a number of years. It looks like you want to say something, Connor.
I just want to add on to that. So Andy had said, in the U.S., we sort of wait until you know that something is wrong. So I want to put in a plug for our littlest ones and getting to schools, getting to pediatricians, getting to OBGYNs so that we are addressing that 0 to 5, addressing kids before problems start in preschool, K through 12. And we're seeing that happening across the country in different pockets. California's got an incredible investment in child and youth behavioral health, and I know that's also happening globally. But those early years are just so important because we can prevent so many of these, as people have talked about. We can make those brains as resilient and strong as possible before other problems set in.
So let's pull up a little bit and let's shift to what needs to be true to enable more global partnerships around some of these issues.
I will just jump in. I mean, I think it's just such a common refrain is just we do not have alignment on the outcomes that we want to see. And when we don't have alignment or when we disagree on what is the right outcome, people from, and we're talking about getting cross-sector collaboration, people from other sectors are like, oh, these brain health people, they don't know what they're talking about. They don't know what works. They don't know how to measure good outcomes. And I was like, no, we know. We just have like 1,000 different ways of doing it. So like there's 4 of us here and we'll have 4 different definitions of like, how did we address depression? And so that, I think as a community, we can work together, show leadership and create that alignment so we can bring in people from other sectors who may not be as nuanced as we want to be.
I think we heard earlier today the importance of just increasing baseline awareness so that we don't have the fear of all things neuro from our physicians and from our families and the public generally, or politicians. So there's a, how do we increase the awareness, the conversation that's necessary within the space of people that could invest, that could change policy. We do need to show and build a space of more alignment, so that we're showing that as a community we have a direction, that there's a North Star of actually improving brain health overall. And I think the last, and it feels like almost nuanced, but it's quite real, is the legal frameworks of data sharing, of research sharing, so that the work can get done. And so thinking about how do we build those bridges all along the way, so that we understand the brain in a similar manner around the world, and we understand why it's important. We are able to show a cohesive direction forward, and it doesn't matter what disease area we're talking about, or phase of research, or where you are, but that there's a necessity to have brain health for long-term whole person health, and that we actually are able to share and build that direction forward across borders, no matter where you are. That's what I would do.
Well, if only you were in charge, Kara. No, but I think both of you are hitting on something that's really important, that even within the mental health and brain health community, we often can be siloed. And if we're really going to translate all of the great reasons that were brought up today about the magnitude of the problem, both on our healthcare system and our economies, we've got to stop being so in the weeds and lift up. We talk about it at the Institute as identifying the flowers in the treetops, who are the real deciders and influencers to drive consensus and unity around the priorities. We are more alike than we are different. And I think sometimes we are our own worst enemy. And I don't know if others have comments in response to that, or debates.
I'll just echo what Kana said around shared vocabulary and shared definitions. Maybe I'll make a small addendum. Maybe, and I don't know if this would be a project for McKinsey to take on, but but a shared maturity framework, because Pakistan, where I come from, is at a very different point in this journey than where the United States is. Where stigma is in Pakistan today was perhaps where the US was 15 years ago, right? And so to expect or ask of the same types of investments would perhaps be, even if we had a shared definition of vocabulary and objectives, just like in the climate conversations I'm sure that are happening, there needs to be a little bit of calibration on helping countries come along for where they are in their journeys. And this isn't necessarily indexed to countries' income levels or GDP. Like, you have countries like Argentina that have the highest per capita number of therapists in the world, right? So this needs to be really customized and tailored, and giving countries mechanisms to peg themselves in that framework, and then help them figure out where to pick up from on that journey.
Okay, as we're wrapping up my portion of the Q&A, I'd love to just go down and have you each respond with one sentence on what is one thing that we can do to be more effective at importing or exporting knowledge and collaboration.
I'll jump in. I think when it comes to good ideas and successful enterprises, we should not be afraid to steal liberally and tailgate freely, because I think things like climate, things like HIV/AIDS, things like maternal health, there are other movements that are out of the chute and going, and I think we need to tag on to that and align ourselves to share that success and bring them more success, because we bring brain health.
So don't reinvent the wheel. Look at other sectors that have bridged silos and borders and build from that. I like it. Tanish?
Follow the money. And by that I mean is, I think there are pockets of where this is already happening, and I see this in the VC community quite a bit, right? We see, we're a small venture capital firm based here. We see investment opportunities from all over the world, from the UK, from Singapore, from Africa, different parts of Africa, and there is a lot of mental health innovation happening in those countries, and maybe using that as a starting point, because there's a lot of sense of urgency around those things, and those things are moving and they're getting done. So using those as a point to create a nexus for collaboration that can then expand from there.
So I just want to summarize, follow the money, heard that loud and clear, but you see an opportunity to actually unite or weave together various funding streams behind a common mission.
Absolutely, and use the shared funders as a point to build those connections, right? Sometimes it's nice to come from the top at the agency level and collaborations at health departments, but sometimes it's nice to go from the bottom and say, this startup in Kenya, okay, we're interested in funding it, but who else in Kenya is funding it, and what else are they doing, and what else are they involved with? Because they're likely to be the ones who are cutting edge or innovative in that field, in that domain.
So like putting together a mosaic of funders
Exactly.
pointed at a single problem. Great.
I think this summarizes what's been said, but listen to communities that are able to really tell you what they need and what the problem is. Listen to other leaders in the space and what's working so you can understand what can scale, and listen to funders that have an actual interest in investing and carrying a space forward, because they are part of the engine that drives it all forward.
I love that part too, Kara. I'm reminded, or I try to be reminded regularly, to think about like what does my customer want, and is my customer the person dealing with mental health challenges, or is my customer the funder, or is it both? I think I know I've grown up in this community where I've had several experiences that have changed the way I think about problems, when I've had the experts on one side of the table telling the customer what was best, and the customer said, I'm never going to do that. I don't care if you think it's the best thing. And if we don't engage our customers from the beginning, I think we're going to continue to hit roadblocks when it comes to collaboration and breaking down silos. So I actually am going to turn it over to the panel now, because I need to run to catch a flight. And so I think we have a little bit of time for Q&A from the audience, Fred? Yep. How much time do we have? 5 minutes. And I'm going to say Danush is in charge.
Okay, all right. It's okay. It's good because they're better at answering questions, so I'll just be the one who calls. Why don't we start? Yeah.
Hello, good afternoon. I'm Florent Bernard. I'm representing the European Union, actually, in person in the room. I'm the science counselor based in Washington, D.C. And actually, you'll be happy to hear that I don't come here with a question, but I come here with solutions, because we're offering fundings. European Commissioner Kyriakides mentioned a program which is called Horizon Europe. I'm sure all the European in the rooms have heard about it. If you can raise your hands. Yes, hi, yes, very good. The good news is that this is an international platform. It's not just for Europeans. We have 142 countries participating in that. We are funding all LMC countries, okay? So our friends from Nigeria that we heard, this is the platform you were looking for. Friend from Malaysia also. And our friend from the International Brain you were looking for an international platform, this is it. We're also funding in the health sector the US researchers. So I would like to ask the European in the room to network to their fellow and to bring their US and international partners fellows to those platforms that we are funding. Actually, allow me to share that my job is to travel the world. I've been to China, I've been to India, I've been to the Middle East and to Africa to promote this program. So it's such a relief to have you all in the room in one place and inform you about that. So feel free to give me your business cards, maybe pass it on, or we can meet after. I'll have to leave at 5:30, so happy to talk about it. And thank you for allowing me to speak on that.
That's the best kind of question.
Has money attached.
Hi, Steve Carnevale. I'm with the California Mental Health Commission, but I'm also my day job is in venture capital. And Casey knows this. I agree 1,000% with everything you said, and in particular, this gap between the public and the private sector. But I think here's a conundrum. I think everybody operates based on their incentives, and venture cap. What you said, but the customers are right for the companies. The customer for the venture capital firms are the investors, mostly institutions or high net worth. And as long as you're 100% focused on optimizing around profits, I believe that gap is going to continue to exist. How do we create a different financial structure, incentives that will encourage a bottom line impact where you can still make money, but you can support impact in the public industry? I think that's the elephant in that room. Thank you.
Great question. I guess
Do you want to answer?
maybe I'll take a first stab at it. Thank you for the question, Steve. So I think you raise up a really good point. We've seen this in a lot of industries that have, and most industries have, some kind of public impact. That impact, those externalities are not factored in by the industry. Mental health and brain health is such a critical industry where everything is an externality at the end of the day, right? The positive and the negative has an impact in society. So we have to be very mindful of that. I do think that there is maybe the way we think about it and the way we wrestle with that question, and it's not a perfect answer, is one, a lot of the venture capital firms, ours included, but others as well I'm seeing, are going to capital sources for their funding that are mission aligned and that are impact aligned. And so they're not going to your traditional LPs, at least to a majority extent, right? And for us, for example, we are very fortunate to be backed by families that care about these problems, and they do care about a return, absolutely, but they would not back us if they felt that we would do something that would harm society. But at the same time, at scale, how do you solve that problem? I think that the second way we grapple with that question is we say, how do you make sure that the builders are informed and have at the table from day one this collaborative of expertise around policy, regulatory, and clinical. And I think if you surround entrepreneurs with the right support, that solves things to some extent. But then, most importantly, how do you fund the things? You solve the profit question by saying, what are the problems that are the most impactful to society, the ones that can have the most scale? And if you focus on those problems that can have the most scale, then I think you can intersect the returns objective with the impact objective without seeing too much divergence. Now, there will be bad actors and there will be some things like that, and we will see some mistakes along the way. But I think we're seeing a positive alignment there.
Mm-hmm. And so, Steve, thank you for that question, because we are having this conversation tomorrow at a roundtable at CGI on exactly this topic about how to spur more innovative financing approaches in mental health. I think, we see things like the Resolve program in New South Wales, where the investors are paying for programs out in communities, and then the government is coming back to pay for the outcomes that those investors have helped the community achieve, and they're looking at 7.5% returns. So it's not double-digit returns. It's not, it's not what you're looking for as a typical PE or VC, but they are being mindful and they are delivering for investors, and I think that's the kind of double bottom line of social impact that is possible. And I hope that we can also see things like, it's also we sometimes fail to see the opportunities that exist. So like State of Oklahoma has a tablet program where they're getting tablets out to 30,000 individuals who are experiencing mental health crisis, connecting them to 24/7 access to care. And they have seen a 99% reduction in emergency department use by that population and a savings of $15 million. The commissioner says the program paid for itself in the first year. So it's not like these opportunities aren't out there. We just have to also get over, we have to take a more investor mindset to what we do and how we fund it.
Thanks. I'm Samantha White, Managing Director of the Stavros Niarchos Foundation Global Center for Child and Adolescent Mental Health at the Child Mind Institute. Yes, it's a mouthful. I did want to ask you all for your thoughts as a nonprofit organization that has done quite a fair bit of work, a lot aligned along the same lines of what Andy was talking about earlier in the United States. We're entering into this global arena respectfully, humbly. And so I'm curious about kind of for organizations who are maybe newly entering into the international collaboration space, who are really trying to understand what the needs are from those with lived experience, from those who are actually on the ground, from those where they don't have access to a venture capitalist right on their stage. What are your thoughts on kind of the very best first step? No pressure.
I'll start. So first, kudos to a ton of great work at Child Mind. And from our early lessons in BD Squared, I'll give the example of we've built a large network of clinical centers that will both do deep research and provide best care for bipolar. And our initial was we're going to take this global right away, and we're going to, because that's what needs to happen. And as we got started in the planning phase, we realized that that was probably naive, and even more naive would be to think that we could take exactly what happens in the United States and port that anywhere outside of the United States. That it actually won't work just that way. But what we can do is we can have infrastructure that allows for the sharing of data. We can do that in an open manner. We can have early and often conversations with the very, utilize what is awesome about science, that there are global networks of researchers that do come together and do want to collaborate. And so leveraging existing relationships and then thinking about how do we choose what must be kept, and then what do we allow to let go of while still carrying forth deep, good research and the best care possible. And so we're in the process of it. So I can't say that I've got all of the lessons learned yet. I wish I did. But to really reflect on some of the naivety going in, as we were like, we must do the very best and the biggest. And we had to walk it back a little bit to make sure we did it right and that we engaged the communities along the way, acknowledging that would be a change of plans and a change of, ultimately, protocol.
We're out of time almost, so maybe last thought here. So I think that it would be a shame if we took the U.S. mental health and brain health system and ported it over to the rest of the world. That would be a loss. We should not do that. There's opportunity is just like, in communications, a lot of countries were able to bypass DSL and broadband and go straight to 4G. We need to kind of spark that, right? And that's happening, by the way. If you go to the UAE, if you go to the Middle East, these countries have the capacity, the wherewithal, and the desire to do just that. And actually, there's a moment here where taking the clinical expertise that we have and the scientific expertise that we have, but creating fresh business models from the ground up and allowing the entrepreneurs there who understand the landscape and how to navigate that landscape, partnering with them, can leapfrog what's been done and potentially then bring that back here. So I would focus on those communities, but I'm very biased. Okay, I think we're at time here. I know that Kara is going to be here for 15 more minutes, and Kana's here today and tomorrow as well. So hopefully you can catch them.
Thank you, Danish, for the moderation. Improvised. We now move on to our next session, which is a deeper dive into the innovation space. No, doesn't work. Technology is failing us. Thank you, Danish, for the moderation. And we now move on to the next panel, which is a deeper dive into the innovation space. I'd like to call on stage Angela Genje, Josh Cohen, Justin Clay, and Norman Putsky. So Norman, you'll have to tell us more about your presence here because you're deputizing for a colleague, and we'd like to thank you for that, really. Do you all have a mic? Yeah. Okay, so Yeah, no, but you can try that one, but I don't. All right. So, okay, maybe give it to Norman. Awesome. Could I quickly ask you to introduce yourself briefly, because we'd like to address this notion of innovation and innovation ecosystem in the brain space. But just to have a round of introduction, and Norman, I'll start with you. Short intro, your role.
Hi, everybody. Thanks for having me. My name is Norman Putzki. I'm a neurologist, neuroscientist, and I work for Novartis. I lead our global drug development organization for neuroscience and gene therapy. The neuroscience field in Novartis is one of our core areas of innovation, research, and development. We have about 3,000 people dedicated to R&D in the space of neuroscience and gene therapy. So pleasure to be here with you.
Thank you. Justin?
Sure. Hi, everyone. Oh, is this working now? All right, good. Hi, everyone. Justin. I'm one of the two co-CEOs and co-founders at Amylyx Pharmaceuticals. We're focused in neurodegenerative diseases, particularly ALS. It's really an honor to get to be here today, share a little bit about what we've done so far, but I think largely reiterate what so many here have said today about the need in these areas, the need to collaborate, but also the great hope I think we have for the first time in a long time.
Thank you. Josh?
And I'm Josh, the other co-CEO and co-founder at Amylyx. Really an honor and thank you to be here today. And echoing what Justin said, I think we're in a unique time in neuroscience. I don't think there's ever been the opportunity and the chance to make a change in these diseases as well as in mental health, as there is today. So I'm excited to be up here today. And co-CEO and co-founder at Amylyx, been with the company since I founded it with Justin a little over 10 years ago.
Thank you. Angela?
So which of these is not like the other? I'm Angela Genge. I'm a neurologist. I am from the Montreal Neurological Institute, McGill University, amongst other things. And I have run a clinical trial unit which focuses on drug development across neuroscience for about 20 years. I'm an ALS recognized rare disease, specifically ALS expert. So I consult a lot with small biotechs that don't have a lot of money when they first come to me, trying to figure out how to get their drugs into the drug development space. And I'm delighted to be here.
Thank you. Norman, I'd like to come to you first, maybe for you to give us a little bit of insight of what's cooking in Novartis, you've got in the pipe. Many are talking about the golden age of brain science or golden age of brain innovation. We'll come to your colleagues in a moment, but we wanted to start with you first.
Right. Thank you. I feel we might be aligned on this idea that this is the golden era of neuroscience. As somebody who has spent his entire career in neuroscience, you can imagine that I come with a couple of biases. But this being said, I think we are currently experiencing what I think is kind of the perfect storm. So several disruptions at the same time. We understand the biology better. We understand the diseases better. We have better technology to develop targeted, innovative approaches to those pathways and targets. And I think we have also technology advancing at a rapid speed that really allows us to detect those diseases earlier and also to measure them better. And I think all of this is required to really deliver the breakthrough that we will need, particularly in the space of neurodegenerative disease. And what that means, we can talk about this in a little more detail. When it comes to Novartis, we have spent the past 2 decades, I would say, very heavily in the space of neuroimmunology, multiple sclerosis specifically, and I think this has put us in a very interesting position that we can translate some of those learnings in the space of neuroinflammation now into what I call immunoneurology. So in the space of those neurodegenerative diseases, including ALS, PD, AD, there are numerous opportunities to really translate those learnings from those pathways into neurodegeneration. And I think that's a really exciting opportunity. And this is where, when you look into the pipeline of various industries, not just Novartis, there are numerous opportunities emerging there. So we spend a lot of time in the immunoneurology space, but generally expanding in neurodegeneration. We have a couple of active programs in the clinic in ALS, in Parkinson's disease, and in AD. We are also focused on rare neuromuscular disorders, specifically with our gene therapy and other innovation approaches. We now have multiple really exciting gene or gene-related platforms in the company that allows us to hopefully deliver what I call erasing progression in this space, really. So everybody on my team has this sweater that says erase progression. That's really what we stand for across those three core pillars in neuroscience and gene therapy. We currently have 10 clinical programs. These are 50 trials, and we're touching the lives of about 20,000, shouldn't exaggerate, 20,000 patients with our programs.
Thank you. Justin, I'm tempted to pass it on to you. What are you going to write on the T-shirt of your collaborators?
Yeah, it's a good question. I mean, I'd say for us, it's really about partnership and having patients first. I was also struck by the earlier conversation about kind of the double bottom line and can a corporation be profitable while also doing good. And I'll say that we very much took it. So Amylyx recently got a drug approved for ALS. In the U.S. we now have over 3,800 people on therapy. But we also took that very much as an opportunity to reinvest. I mean, I think it should be almost the obligation of a pharmaceutical company when you get a drug approved in the space to really dive into that space and see what else you can help. For example, in ALS, we know that diagnosis takes too long. We know that all of the disparities that affect really every disease are just as significant in ALS. If people are in rural environments, if they're minorities, their access to care is much lessened, and the outcomes are correspondingly worse. So I'd say, for us, we think that, there's a tremendous opportunity, not just in terms of, the drug development, which we certainly are doing. We have the drug approved, and we've started to reinvest heavily in research in ALS as well, but also to invest in the community and in things that we can change there.
Justin, you'd like to complement that?
Yeah, sure. I mean, I think just looking at maybe our history for a little bit. So Josh and I started Amylyx when we were still undergraduates, and we thought we had a different way of looking at neurodegenerative diseases, which was focusing more on the pathways that lead toward neuronal degeneration and neuronal death. And we thought maybe by targeting that, we could have one part of erasing progression. I really like that. And I'd say that when we started out and we were doing research in ALS, as Angela can share, there really weren't many companies in the space. But what was so rewarding for us was there was this wonderful research community really dedicated to try to help people who really need it, and who had developed also all of these wonderful outcomes and ways of tracking progression and running clinical trials. Fast forward to where we are today now, and while we're really excited about our approach, in some ways the most exciting thing is how many more companies there are in the space, how many more treatments there are. And I think we all in the space believe that the ultimate solution is going to be combination treatment. It's going to be different cocktails, perhaps even for different parts of the population. I think we've seen successes in virtually every other disease. Oncology certainly comes to mind, where the more we learn about the population, the more we find out that we need to have broad treatments that target different parts of pathology, and we need to have targeted treatments that really get at specific areas of the population. But I think the only way that we're going to continue to advance that sort of vision is if we have a really comprehensive partnership. And so I think something that I'm so excited about being here today is hearing the themes that are the same wherever you are in the world, whatever disease space you're in. It's the same themes over and over again, where we need the research funding, we need the biomarkers, we need companies, we need NGOs, we need, on and on and on in order to solve these things. So to get to be part of what we really see as a revolution in brain sciences is just tremendously exciting.
Angela, you'd like to share that vision of that positivity and that vision of hope, and I mean, how does that inspire you as a researcher?
So I think the most important thing is to put it in context, because we've heard some incredible stats today. Numbers of neurologists in India, numbers of neurologists in various places, and so and that makes us feel somewhat small, because we see the impact that we're having in a few lives. But I'd like to take it back to one step to understand why I'm an optimist. So I come from a very small province in a not particularly populated country, right? I come from Newfoundland, which is in Canada, which is, I think, 3% of the GDP in the world. Like, we're basically irrelevant, except we're so large that you just can't ignore us because you have to fly over us all the time. And when I started in neurology, I'd done internal medicine. And when I started, HIV was a full-out epidemic. And I was helping my colleague who ran the NeuroAIDS clinic, and these guys were dying, right? And physicians wouldn't go in their rooms, and they were neglected. It was a horrible history of medicine that was going on. When I started, young women at age 30 with MS were dying because we were treating their UTIs, their urinary tract infections. That's all we could do for them. We were afraid to give them steroids. And when I started, stroke was even worse, right? You didn't even bring a stroke patient to the hospital because there was nothing that could be done. Fast forward now, MS has somewhere around 13 approved drugs. We never take a single symptom lying down. We treat everything. HIV is a model for drug development for all of us. Raise enough awareness, raise enough funds, you can solve anything. And stroke is now the equivalent of an MI. You have a stroke attack, you get them to the emergency room, and you can prevent the devastating weakness. So, but I'm in ALS. Like, isn't that the worst disease ever? In fact, most neurologists think that ALS is actually worse than all of these other diseases because ALS creeps up. Your golf game goes down the tubes. Somebody accused, all of these stories are true. My handicap has gone down, doc. They sent me to a neurologist. Why? I fell off my horse in a competitive equestrian event because I couldn't hold on. That was a 21-year-old. My colleagues told me I was drunk while I was speaking to an international banking meeting, and I don't drink. This is how this disease starts, right? It's 5 years from symptom onset. The diagnosis can take up to 18 months, and you're perfectly healthy while you're dying. It is a horrible situation. And it is a big group of people who just go from perfectly normal running a bank, running a Fortune 500 company, to actually senior executive in a pharma, to calling me out of the blue because the drug is available through me, through a phase 1 clinical trial, and it's not available in the US because the FDA is worried about the side effects. So these programs are now starting in Canada. So why am I still an optimist? That's pretty bad, right? Because ALS is the poster child for all of neurodegenerative disease. When we solve ALS, we will solve Parkinson's, dementia, because we will understand some fundamental issues. We have these lots of young companies. These are the youngest CEOs of everyone I deal with, but there are a lot of young companies. And they're really excited and they're passionate about their molecules. And they're pushing forward a little faster, may I say, than Novartis.
Well, let's let Norman respond to that, maybe, because... okay. And I'll come back to you definitely. Yeah. But Norman, just to summarize also, what other panels were saying in other sessions, talking about the burden, talking about the policy awareness, talking about the initiatives launched by WHO with the Global Action Plan. I mean, these fantastic opportunities, and we now mention, and we had a panel even on basic neuroscience with all this excitement, and now it's delivering to the market. But what is it still that we need to address? And if you'd like to respond to your neighbor on your left about, the pace of progress within Novartis, feel free to do so.
Yeah, you know, make me feel old. It's a contrast effect for you guys are young and slow. But we do a lot of things, and we have a lot of things in common that we want to accomplish. And so let me tackle the question of, you know, how slow is too slow in a company like mine. I'm sure our decision-making process is way slower than yours. And in an organization that has about 100,000 employees, you can imagine that can be an issue. When I look into neuroscience, I think the breadth of what we can do from research to development is just really outstanding. And for us, we continuously need to reevaluate our focus. And I think it took us a good 10 years. I've been in this company for 10 years. I was a biotech before when I was still younger. It took us a good 10 years to come to this point of really translating neuroimmunology into immunoneurology and all these consecutive steps. Think about xRNA therapies, think about gene therapy opportunities in this space. I think these are all terms that didn't exist 10 years ago or 20 years ago when I came to the clinic, and that we share the same experiences. And so if I look into what happened over the past 10 years, and I believe history tells us a lot about the future, then I think we are in this era where we can do much more. What I think is instrumental, and I was really inspired in the previous during the previous session, the theme is exactly the same. I think what will catalyze our efforts together as a community will be collaborations, and it can be any kind of collaboration. It can be collaboration between companies like mine, pharmaceuticals and biotech, and it can be pharmaceutical companies. It can be it should be policymakers. It should be the healthcare system, and of course HCPs and the patients and so forth. Without that collaboration, I think we would just be slower, and it will take us longer to actually get those molecules that hopefully become medicine to the patients. For our space of neuroscience, I think it's so fundamental to work on the collaboration because we know of the significance of early diagnosis, accurate diagnosis, looking at the modalities that we're using, and also better disease monitoring and rehabilitation. And these are like key milestones, I think, during a patient's journey. And to tackle this more effectively will require investments, but there will be tremendous return of investment if we get this right. So when we get this right today, I think in a clinical trial setting, there's been massive progress with all of this. And now is the time to translate this into the healthcare systems. And there will be a return of investment, but we need to put money on the table in the first place. And these investments will change how we think about neurological, neuropsychiatric disease.
Mm-hmm. And Angela, I'll come back to you to respond to that in a moment. But I wanted to ask Justin, you mentioned the genesis of Amylyx when you were undergrads. I've been told by your colleagues that you had a seed funding from the Ice Bucket Challenge. Is that right? So that means that philanthropy and crowd-funded based philanthropy actually delivers. What is the path to success before Amylyx become? I don't know if you are planning to become as big as Novartis, but what is your vision of progress and the challenges that you have on the way ahead?
Yeah, well, I'm so glad you asked. Thank you. And yeah, as probably many in this room can imagine, we didn't have the most compelling pitch when we started. So we had no background, we had no graduate degrees, we had. We're going after diseases that historically have been very challenging. And we had one asset. Investors tend to like platform technologies. So when you add that all together, I can tell you that most of the answers were, I really hope you're successful, but I'm not going to invest in that. And along comes the Ice Bucket Challenge. And it was at a time when we were right at what can often be the valley of death for pharmaceuticals. So we thought we had a promising idea, but we now needed to go into toxicology studies and get into clinical trials. And nobody wants to fund that. I mean, it's, at the end of the day, you fund it, and if you're successful, they say, okay, your drug's not toxic. No investor, that's not sexy, right? Like, so...
well, that's a positive start in a way.
Yeah, exactly. But so the Ice Bucket Challenge happened, which for those who who don't know, that was started by two people with ALS and their families, Pete Frates and Pat Quinn and their families, and they started a challenge where people would dump ice water on their heads and raise money and awareness for ALS. And suddenly, first in the U.S. and then expanding, ALS became much better known, and critically, there was funding where there wasn't before. So the ALS Association, another group called ALS Finding a Cure, came out with an RFP for a clinical study, and based off of that funding. And we were one of the first recipients of that. And so at the time, it was a $3 million grant, which for us was more than we could possibly imagine. Now, as anyone in drug development knows, that's a drop in the bucket in terms of what it takes. But for us, it was absolutely catalytic. We wouldn't be here if not for the Ice Bucket Challenge. And now we're very proud to say that we have an FDA-approved treatment because of that. But to me, it also highlights, again, the challenges here and what I hope that this group and maybe the more global community can start to solve. It shouldn't take an Ice Bucket Challenge for a drug like ours to be able to get to people who need it. We need to have the funding to take those crazy ideas. Maybe they come from a dorm room. Maybe they come from much more established companies. But we need to get those into people to see if they can really be treatments that can help. We need to recognize that when there are those challenges, that innovation can come from anywhere, and that it's really the work of multiple stakeholders that are going to solve these things. We're a company that our primary goal, of course, is to develop treatments for people, but we care deeply. I mean, we've lost many friends to this disease, so for us, this is very personal, which means that if there's initiatives that have to do with care, if there are initiatives that have to do with how can we diagnose the disease earlier, sign us up. We want to help just as much as anyone else. So I think that when I think there's a more global effort recognizing the urgency, but also the number of interested stakeholders there are in these things, that's when we can really start to get to the innovation, inflection point. And I feel like we're just about there, and I think getting a group like this together is a really great starting point for that.
Thank you. Josh, would you like to complement that? And feel free to disagree with your colleague. I mean, it's
strongly disagree. I think a couple things just to highlight as well. I think it's also important, talking to you today too, as well, about low and middle income countries as well, just how global these diseases are. Just maybe a few weeks ago, there was a paper in ALS on the prevalence and incidence of ALS in Ethiopia. And the prevalence and incidence of ALS in Ethiopia is very similar to the prevalence and incidence of ALS in any other country around the world. And I think what it highlights is that these diseases affect everybody. They affect the whole world. And, I think it is sometimes the case that as new drugs come around, they often start in the highest income countries and take a while to move past that. And I think that is a challenge really for the world community to hopefully move these faster and faster to as many people as can possibly benefit. I'd add too to the point of coalition and bringing people together, maybe just as a couple examples. So some of our colleagues are here today from Amylyx as well. And one of the things that we were a part of and now has become a much bigger group is the EU ALS Coalition. A group of doctors, advocacy groups, policymakers, et cetera, working in Europe to think about what are those most major things that we could address, certainly on the treatment and innovation side, but also just as much on the care, diagnosis, et cetera. So that recently, came together in EU Parliament, and it was just such a nice moment to see everyone aligned. And one other thing I'll add in our highly polarized political world these days is it felt like a breath of fresh air to all the policymakers as well. Usually the issues are very divisive, that policymakers might face. but there was universal agreement across different parties, across different groups. Who doesn't want to make ALS, a better treated, better cared for, et cetera. So I think the other nice thing about these issues from a policy perspective is they bring people together. Usually there is common ground, there's alignment, which may not always be the case on other issues.
Well, and it's fortunate that you organized the event before the 2024 elections. We'll see what it gives. Angela, I would like to comment on what was said, and I'd like to go back to what Justin and Norman were saying about the care pathway and the attention that companies like Novartis or Amylyx would dedicate to the holistic approach to patients and the holistic management of condition.
Thanks, Fred. Every partner in this contributes, right? In ALS, and again, I remind you, this is the poster child for all of neurodegenerative disease. Is one of those things that has a tremendous groundswell of support. We have the ALS MND International Alliance represented here today, as well as myself and a number of others, including the guys on the podium. There are initiatives in every country. I spent last week traveling. The guys know this. I started my week with the FDA CPATH Institute, where a couple of years ago, you may remember, the Congress passed a bill putting a ton of money into called the Act for Neurodegenerative Disease, really to support everyone sitting up here, plus all the clinics and the patient groups. So you've got the European initiative, you've got the big ACT initiative, which is doing a lot of things. And then I spent 3 days in Malaysia, in Kuala Lumpur, because there's a ground roots group called PACTALS, which represents all the countries in Asia. And they presented what they're doing in each country for ALS. It was extraordinary. And then we were there to give them updates on clinical trials around the globe. And, the companies were there talking, and we were talking about how to diagnose faster, et cetera. And their overwhelming request was, can you please bring these drugs to us? We may be small in number in each country. You have a beautiful country, by the way. But we can contribute patients to your clinical trials. We may not be able to do the phase 1s that I do at McGill, but we can do a phase 3, and you can fill your trials faster, and you can show a global interaction. And that was the message I brought back with me. And so we're networking the groups all around the world. So you've got patient groups, you have the ALS clinicians and clinical trialists. There are groups in every country, in Europe, Canada, the U.S., Japan, and all the PACTALs, which includes Australia and New Zealand. And so we work very closely together. We mostly know the players in the drug development world. And what we really need help with is sometimes it's policy, sometimes it's regulatory. We have a very weird situation in ALS. I don't think it exists in MS, Norm, where it is possible that we will have 1 drug approved in Europe and 10 drugs approved in North America in 5 years, because the regulators look at the results of the clinical trials differently. And that doesn't even speak to Malaysia, Singapore, Taiwan, Indonesia. So I think there's tremendous hope because we're getting drugs that work, and we have players like Novartis now that have jumped back into the game. But we do have some barriers that a group like this could really help us with. We'd love the regulators not only to talk offline, but come to some sort of consensus so that we can get drugs approved everywhere, so that we can get access to drugs in Uruguay and Argentina, because I get calls directly from Argentina these days, so that the patients and the docs can get access to the trials and ultimately to the drugs. And I know this is true in the U.S. as well. U.S., rich people get drugs. Poor people may not get drugs, even if they're approved.
Thank you. Thank you for these words. We are now coming to the end of our panel, and I'd like to invite each of you to conclude and I would probably bring what I would call a magic wand conclusion. So if you would have, let's say, one wish, because we are talking about building an innovation ecosystem. We have identified, let's say, shortcomings, challenges, and so on and so forth. So if there was like one thing, and I'm sorry to say it's not the 3 wishes, it's only one magic wand with single use. So if there was one thing you'd like to change or to improve, what would it be in a couple of words? Josh.
Yeah.
And sorry to put you on the spot immediately.
Jump right to the magic wand, or I end with the magic wand? But so, I think earlier today, I think somebody said therapeutic nihilism is dead. And, unfortunately, I think that there is still a lot of fear in places like neurodegenerative disease, that these diseases have been hard, they've been challenging, and that we're not going to make progress, that we're not going to make breakthroughs. And my view is completely the opposite, that we have more opportunity to make breakthroughs today than ever before. I think one thing that makes brain diseases fundamentally hard is you can't biopsy the brain, right? Whereas with cancer, you can take the tumor out, you look at it under a microscope. You can't do that in neuro. But what we've now have that's kind of replacing that is biomarkers, imaging, et cetera. So my kind of magic wand, kind of the one thing I would kind of leave everyone with is, I wish that there was, broad cross-stakeholder positivity, for neuroscience.
Okay, I like that. And you can count on EBC, by the way, to contribute to that. That's what we've trying to bring over the last years forcefully. Justin.
Yeah, and we certainly know, and we thank you for it too, and your leadership in doing so. I think I'll go along similar lines, but I think as I hope you've heard commonly across the groups here, the science is more exciting than ever. We have treatments for the first time ever, but we need policies and access to accelerate at the same speed as we are on the science side. Because all of the great science that we do, if we can't get access for people, then it's all for naught. And I think these are diseases that take people like that. And so every single delay that we have is incredibly impactful for the people living with the diseases today and their families and communities. I think if we look at the history in other health areas, like I guess I'll bring up oncology again, there was a shift at some point where people said, we need to fight this thing, we need to fund the research, we need to get treatments to people, we need to diagnose earlier, we need to recognize that these are heterogeneous diseases, and we're going to figure out how to manage these things because we're going to keep the people with the disease at the center of all of this and listen to them, hear what they need from us, and that's how we're going to innovate. I think we haven't gotten there yet with these diseases. I think we're getting there, but I think what I'll say for, maybe we in our community make the mistake of sometimes is that we tend to talk to each other. And frankly, we all agree, right? We're really excited with what's going on. But if we can't get those messages out more broadly to policymakers, to people who are not in our communities, then we won't get the access that's so important. So if I could wave the magic wand, it would be for all of the policies and access really globally to innovate at the same speed as I think the science is right now.
Okay, thank you. That's quite a wish. Norman, on to you.
Yeah, there was good stuff. I like how you put ALS as a poster child, and I so agree with that. The reality is that on a societal level, there are problems we need to solve based on what we are hopefully solving for more and more ALS patients, for diseases that you all know, maybe better than ALS even, Alzheimer's disease, Parkinson's disease. So the societal impact is much bigger, and I think we all know as a society that Alzheimer's disease and mental health are the fundamental drivers of disability in our societies. So my magic wish is to act as if we all understood that this is actually the case. And it's not the case. And I think agreeing that these are the problems we need to solve on a societal level over the next 25 years and act accordingly across everybody involved in the innovation ecosystem is fundamentally important, and includes what you already mentioned in terms of diagnostics, biomarkers, the regulators, healthcare system investment into the patient journey, patient groups. Like, we can't do anything without patients and their organizations and the belief in that we want to do the right things to solve fundamental problems for them and then solve them for society in the future. So I think that understanding and the joint understanding of mutual goals in this space would be absolutely fundamentally important.
Thank you. Angela?
So my wish would be to eliminate paternalism in medicine. And what I mean by that is the root cause of patients not getting access, even today in things that are approved, is therapeutic nihilism, is a paternalistic approach. It's not gender-based, by the way. Women are just as bad as men, who go into neurology because they never have to prescribe anything because everything is untreatable. And even now in Western hospitals, you do not get strokes treated as aggressively as they should. When it comes to drug development, that paternalism comes in 2 or 3 different places. And one of them is actually at the level of our regulatory agencies, who decide that a new drug in development, which has been submitted, is too risky for the patient, for the ALS patient community. And to a person, ALS patients will say, "I'll take that risk. Treat us like a cancer patient. Don't treat us like we have hypertension." So therapeutic nihilism exists at the FDA, regulatory agencies around the world. And then the third place that therapeutic nihilism exists is the decisions as to how much benefit is enough benefit to approve a drug. So in that respect, we actually have a good situation in Canada, by the way. We have a really very interactive equivalent to Health Canada who will work with us. And if a patient says, slowing the disease so I can walk to my kid's grad in 6 months is worth something to me, believe them. And the measuring stick is different around the world. Canada is actually one of the better countries to have ALS. I know that sounds terrible, but it is true. They have access to everything in drug development, clinical trials, and everything that's approved. One of the worst places to have ALS right now is in places in Europe, because although everything is there, it's beyond the reach of the average patient. So they know everything, but they can't get anything but a drug approved in 1998. In the Asia Pac, they don't know what they're not getting. So in fact, that's another issue. But if I could have one thing, I'd eliminate paternalism.
Thank you. So we can move immediately to Professor Jonathan Rosand from the Massachusetts General Hospital is associate member of the Broad Institute of MIT and Harvard. Sorry, Jonathan, I probably mixed up your affiliation. But I'd like to invite you to either at the lectern or on stage. Completely up to you, but over to you.
See the slides. Thank you. Thank you very much. It's a great pleasure to be here. Thanks to the organizers for inviting me. Actually, this talk is one with a take-home message. You can take it home to all your friends and relatives, as you'll see. I'm a neurologist and actually a neurointensivist, and everything that I'm about to talk about is motivated by this question that I would get all the time by my patients who survived a brain injury, and also from their relatives, and increasingly from our nurses and other physicians. What can I do to take good care of my brain so that I don't have a stroke, lose my memory, or become depressed? And we would get this question so often that we realized we had to have a really good answer. And that's what led to the genesis of the McCants Center for Brain Health at Mass General. These curves describe the life course for people who have the disease that I've spent most of my career studying, which is hemorrhagic stroke or intracerebral hemorrhage. And I just want to point out the the red and the orange, time equals 0 on the x-axis is when somebody is admitted to the hospital with an intracerebral hemorrhage. And then over the next 5 years, what you see is the red and the orange curve rise as they develop a new stroke, new dementia, new cognitive decline that they never had, or a new episode of depression, the first in their lifetime. And the biology here is that intracerebral hemorrhage is actually the manifestation of chronic progressive small vessel disease, which is quite common among all of us as we age. But what's really striking is that if you look at the yellow, that's clinic patients who are age-matched and have other measures of white matter disease, which is another way of looking at a milder expressions of small vessel disease. They don't do nearly as poorly. So the mission of the McCann Center is twofold. One is acknowledging that as occurs for people with intracerebral hemorrhage, so for the rest of us, we all have curves to flatten. And in particular here you see there's quite a disparity between white survivors and black survivors. So there's an important opportunity for achieving health equity as well. So the next question is, colleagues, what can we do to flatten the curve for stroke survivors as well as for the rest of us? So thanks to many people in this room, many of the individuals who are part of the organizations that have sponsored this meeting, attention to brain health has become widespread around the world. In tandem, so has the attention to the fact that so many of these diseases of aging, and in particular I'm focusing on dementia, depression, and stroke, are associated with modifiable risk factors. So one can estimate to some degree, and for the epidemiologists in the room, please don't hold me to these figures, what proportion could be prevented if we were able to manage these risk factors across the population. So the mission of the McCann Center, as we began to reach out to colleagues around the country and around the world, became very clear. It was time for us academics to do something and to hold ourselves to results that would actually represent impact for our patients, their family members, for our communities. And so we identified this mission: 10% fewer cases of dementia, stroke, and depression in 10 years, 30% by 2050. So how are we going to go about doing that and achieving that? So the key here is the theme that we've been hearing across the day, which is it's multiple stakeholders, financing through multiple streams. In this case, philanthropy has been crucial. Our guiding principles are focusing on the patient experience, the patient voice, meeting patients and providers where they're at, and do everything we can to preserve health equity from the get-go. We're developing tools for risk factor control that can be deployed in primary care, secondary prevention, community-wide, so outside of the offices of neuroscientists, clinical neuroscientists, psychiatrists, and neurologists. Develop safe, effective, low-cost drugs that can be deployed long before anyone would ever walk into a specialist office. Collaborate with champions to identify populations locally, nationally, and around the world with whom we can work. And then measure and track our success. So a quick call out to my partner Rudy Tanzi, who's responsible for our drug development pipeline, and through his in vitro model of Alzheimer's in a dish, we've been able to screen and prioritize all FDA-approved compounds and natural products for bringing through a clinical trial pipeline. And the focus here is on long before symptoms become apparent. It's all in the prevention space. And then another lesson that we've learned is that for patients, at least the patients with whom we talk, brain health is a very confusing and often negative term. What do you tell a stroke patient? And I get this question a lot. Will my brain never be healthy again because I've had a stroke? Or what do you tell somebody who's recovered from an episode of depression or anxiety? Will their brain never be healthy because they're now at higher risk? Or somebody who's managing schizophrenia. So brain health is a very challenging term, and we've found in working with patients that it actually it promotes stigma rather than reduces it. So the challenges also you've heard about is that there's no standard assessment of brain health available. So we've moved eventually from focusing on brain health in our so-called, and we have a brain health clinic, to the notion of brain care and answering the question in a way that confers agency on the individual. So brain care is available to anybody, anywhere, no matter what their history. And it's a concept that can be altered to the community that is specifically investing in brain care. Brain care in Dallas, Texas need not be the same thing as brain care in Savannah or across the world, for example. So to make this concept both applicable in real life and also manageable in some way as a tool, we created the Brain Care Score. And the Brain Care Score is a beta version. It was designed to be as unobjectionable as possible so that when patients were to see it and were to bring it to a conservative person in their community, often a doctor, the doctor couldn't say, oh, this doesn't make sense. So we focused on risk factors for dementia, stroke, and depression that are widely accepted and acknowledge that there's much more work to be done. But the goal here is to make this simple, to make it motivational, and to make it have sufficiently high face validity so that nobody will object, but it's not perfect. In other words, if you just take a look here, you get points for blood pressure, blood sugar, cholesterol, BMI, nutrition, alcohol, smoking, aerobic exercise, sleep, stress management, social relationships, and meaning in life. And we've designed the point systems to try and help people to be more motivated in start in one area, work on another area over time. But we anticipate that the scaling of this, the scoring, will evolve as we learn more. But keeping in mind that this is a motivational tool, it's not meant to be the perfect risk prediction tool. But just to demonstrate validity, and I'm sure all of you would agree, given the list of risk factors that are part of the score, you're not going to be surprised. When you look at the UK Biobank, 500,000 individuals who have been followed prospectively for an average of 13 to 14 years, you see in each of these boxes here on the upper left, that's dementia over time, depression over time in the upper right, then there's stroke over time in the lower left, and then the composite. If you break the brain care scores derived from the cohort at baseline, in other words, when they started to participate in the UK Biobank, and you divide them into quintiles, those who have the highest brain care scores in the fifth quintile, you can see, have a substantially lower risk of the composite or of depression, dementia, or stroke if you break it apart. So I think an important message here is that, and I think it's probably no surprise to this audience, risk factors for dementia, stroke, and depression are shared. So one of the reactions that our patients will give us is, if I just follow my brain care score, does that mean I don't have to worry about other risk? What about my heart? Well, the good news is that the same risk factors are for heart disease. So for individuals who are motivated to take care of their brain, they can just focus on the brain care score and they can simultaneously reduce their risk for heart disease as well as for many cancers. So we've started to build a global community of people like me who've had enough and are ready to take all they've done in their academic careers and begin to focus on results for their patients. And so we've got a number, thanks to the NIH. I want to call out NINDS for funding a very important study that has allowed us to build a consortium in the US. And then in addition, we have begun to engage other centers around the world. So the goal is to have like-minded academic leaders commit to building community around their local centers to make interventions, do the studies necessary, and measure the results in terms of dementia, stroke, and depression. So this was the first meeting of we're calling ourselves the Brain Care Coalition in June in Boston. And so how are we going to scale? And we see ourselves as the kind of clinical implementation research arm of this extraordinary community that's been assembled here today. So you'll hear more from other partners. And I really do want to call out the importance of, as we've heard before, the diversity of our funders. Different aspects of our mission have been funded, importantly, most of all by the NINDS, second of all by the American Heart Association through the Buer Foundation collaboration, which is funding a really important network, a network trial where we are, for the first time, engaging patients and family members at the outset of our study, which we've learned, unfortunately, the hard way is really the most important way to go, because our challenge is engagement. And so I'll end with that. Engagement is where we aim to succeed, engaging our patients, our families, our communities, and ultimately our policymakers and funding agencies to make this change and achieve 10% in 10 years. Thank you.
Thank you very much, Jonathan. And actually, thank you for also providing answers to some of the questions that were asked this morning. So it's very interesting to see how that can unfold and actually give us a perspective for the future, and that actually feeds into the later session of our afternoon. I'd like now to call on stage Professor Joanne Occhipinti. Is that the right pronunciation? Yeah, okay. So I see that you, yeah, well, no, let's not go there. But Joanne, you've made a long haul to come and be with us today. You're coming from the University of Sydney, and you're going to talk to us about mental wealth, which is probably a new concept after brain care. So all new ideograms and neologisms that we will need to factor into our narrative for the future. So if I understand correctly, it helps shaping economic and social environments to foster brain capital. So Joanne, over to you.
Thank you. Thank you, Fred. A pleasure to be here. Over the next few minutes, I just want to shift focus a little because globally we're at a critical juncture. Climate change, rising inequalities, food and energy insecurity, polarization and misinformation are converging to cause enormous socio-political and economic consequences. These global challenges are weakening democracies, they're eroding the social fabric of communities, they're undermining progress towards SDGs, particularly mental health, and they're posing threats to social and economic stability. So how do we get from this current state to a future that better supports human flourishing? Well, first we have to understand how we got here. I think most people in this room understand that economic systems, environmental systems, social and political systems are all dependent on each other. So with that understanding, let me take you back about 60 years to the founding meeting of the OECD in December 1960. Now, while GDP had been around since the 1930s, this meeting firmly established economic growth as the foremost global objective. Member nations signed a convention pledging to pursue the goal of the highest sustainable economic growth, driven by the aspiration to enhance living standards and foster global economic development. Certainly a noble ambition at the time, given they were in the shadow of 2 world wars and the Great Depression. So growth in GDP from this point was catapulted to the top line indicator of a nation's good management of their economies and the welfare of their nations. Economists, and no offence to any of them in the room, economists and governments devise policies and reforms to enhance economic efficiency and optimise macroeconomic structures to achieve that consistent growth in GDP. But systems science teaches us that an overemphasis on optimising one system can destabilise interconnected systems, giving rise to a broad range of symptoms that we now recognise as the social determinants of health and mental health. We have been in such ruthless pursuit of greater and greater economic efficiency and worker productivity to achieve that continuous growth in GDP that our health, social, political and environmental systems are now showing significant signs of deterioration and fragility. And when we destabilise other systems, this in turn undermines the economic system. So today we face polycrises that will have profound impacts on our way of life and on our very capacity to respond resiliently to looming global threats. For example, as we approach the carrying capacity of our environmental systems, a scarcity mindset is manifesting a sense of insecurity and anxiety about the future. This is giving rise to hypervigilance, to distrust, disconnection, fear, and a general breakdown of cooperation. The very cooperation we need to respond effectively to global challenges. Systemic problems require systemic solutions. And that is the ambition of the Mental Wealth Initiative, to work systemically to redress the imbalance we have created over the last 60 years or so, and to provide the science needed to transition to a well-being orientated economy. Without systemic action, we are to a large extent only treating the symptoms, and huge amounts of resources will need to be continuously invested to meet the needs resulting from demands for human services. So through the infrastructure of a national mental wealth observatories, we aim to establish 6 overlapping streams of activity. The number one priority is to measure, model and forecast the mental wealth of nations, harnessing complex systems modelling and simulation to better understand which policies across which sectors will deliver the greatest benefits both to the economy and to social well-being in balance. Other streams aim to bring together data from across sectors to support brain capital research, and Harris will speak in a moment more about brain capital, undertake policy advocacy and knowledge translation, and engage in science diplomacy. And that QR code on the side there takes you to a policy memo that we are just releasing. So what the last 60 years has shown us is just how powerful global uptake of a single metric can be in shaping the world in which we live. So I'm going to focus a little bit on that first stream. There have been decades of attempts to develop alternative indicators to GDP, none of which unfortunately have been successful in displacing GDP. And that's because the system of national accounts that underpins the calculation of GDP provides a global standard for measuring economic activity or economic production, and its infrastructure is extensive and it's entrenched. But it has evolved over time to encompass a wider range of activities. So the mental wealth metric simply seeks to expand the boundary of production further to include the value of currently unpaid activities that contribute to the social fabric of nations. And these unpaid activities include volunteering, charity work, caregiving, civic participation, environmental restoration and others, and they're collectively known as social production. And the term mental wealth the term mental wealth was really chosen to emphasise the importance of our mental assets and mental health or brain capital in driving both our economic and our social productivity. And of course, the quality of a nation's brain capital depends on an interplay of factors, many of which we've been discussing today. So why should we include the value of social production in GDP? Well, social contributions are the glue that hold complex societies together. They give us a sense of belonging and purpose and connectedness, which fosters our mental health. They support our ability to be productive in the formal economy. They improve environmental well-being. And they also give us surge capacity to mobilise effectively in times of crisis. So in essence, social production makes nations more prosperous and more resilient. Valuing social production also promotes the narrative of a contributing life, that our value extends beyond simply making money in the formal economy. And it will help shift the narrative not just from one of continuous growth in GDP, but also one of balance between economic and social production, thereby directing policy more towards achieving stable, inclusive, and sustainable prosperity. But there's another very important reason for paying attention to social production. The current shift from the age of information to the age of intelligence is poised to reshape the global workforce in unprecedented ways. Estimates by the Brookings Institution suggest that approximately 60% of work tasks in the US are facing medium to high exposure to displacement by AI in the coming decade. By comparison, the Industrial Revolution took place over more than a century. So this transition will happen at an unparalleled speed and scale. And there are signs that this has already started. Now, historically, technological job displacement did bring with it unemployment, but through upskilling and the emergence of new industries and opportunities, new jobs in the formal economy could be secured. But this is fundamentally different. Generative AI is an intelligence. It is fast developing the capacity to learn by experience, to adapt, to strategize, and to create new knowledge that surpasses human capabilities and inputs. So upskilling may not be a viable solution. And we know from research that productive activity is essential to our mental health and essential to our social well-being. So in this scenario where the need for human input in the formal economy might be diminished, social production emerges as a very important alternative avenue for human ingenuity and productive purpose. So to sum up, we are where they were. This is a pivotal moment where we need to join forces and act systemically. The thinking and tools that got us through the 20th century are simply not suited to the challenges and threats of the 21st century. So our fundamental task is to work across disciplines to develop the scientific insights and innovative policies to restore systemic balance, build brain capital, and foster the mental wealth of nations. And we very much welcome others to join us in this global endeavour to shape a new future, a future that enables every person to live a contributing life. Thank you.
Thank you very much, Joanne. And I'm pleased to bring on stage another Australian, but who is a little bit more local, as he lives in the US. In doing so, I'd like to thank you, Harris, for having contributed to the setup of this event with quite a few other partners, but definitely your help was really instrumental in putting it together. So you're going to talk to us about brain deals, yet another neologism, to harness AI and drive SDG implementation by 2030. So over to you, Harris.
Thank you very much, Fred. It's just wonderful to see everyone here. So many friends and colleagues from around the world. So thanks for making the time. The title that Fred gave is actually the title of another event we're doing tomorrow. I know, but so we're already at capacity for that event, but we have surge capacity. So anyone that's interested, come tomorrow to Steelcase. Come talk to me or Leah, and we'll give you the details, and we'll just cram in there, and it'll be great. Because that day tomorrow is really talking about whole of economy changes with neuroscience to drive SDGs. But today I want to talk about another systems approach here. Maybe the Aussies are talking about systems, from Joe to me. I'm going to talk about harnessing and leveraging and moving the industrial system forward. So this is a very left field way of coming at brain health at scale. and I was thinking I can come from left field because I'm either coming from California, which is the left coast, or I'm coming from Australia, which is even more left field. So anyway, that's maybe a dad joke because I'm going to be a dad in about 4 weeks for the first time. So that's anyway. I didn't realize it was a dad joke until I'm just saying it out loud. Okay, now let me stop talking nonsense and get into it. So let's talk about enhancing brain power and enriching economies. Today, I am formally launching this industrial strategy. So I don't know how many of you thought that we'd be launching an industrial strategy today, but we're doing it. We published this paper on Thursday of last week, and it's getting a lot of attention and interest, which is wonderful because it was a labor of love, and I don't know how many, 60 co-authors or so, many of whom are in the room. So we are talking about a brain capital industrial strategy to try to really rethink how we can improve brain health at scale. Brain capital is this term that you've all heard about today. It includes brain skills and brain health. So brain capital is like the brain health of nation states. It's a term kind of like that. And so it's brain health and brain skills. The skills piece means skills that are relevant to the modern economy, like creativity, like digital literacy, like resilience and adaptability. So that's what brain capital is. It's really a framework. Kind of like emotional intelligence is like a framework. Brain capital is like a framework. And what we propose that brain capital is really under siege. We propose that brain capital is so much under siege, as Joe so eloquently noted, and IHME earlier today, that brain capital now needs to be put as a critical pillar of nation states. We need to think about brain capital as important as GDP, road and bridge infrastructure, forest health and ocean health. So we really are trying to rethink the governance of nation states when we talk about brain capital, and it means policy, and it also means investment innovation too. So these are all the ways that we think brain capital is under siege. It's costing trillions of dollars, of course, and we're really not getting a handle on it. So again, we need to think differently, hence thinking about systems. The challenges we all know: chronic stress, COVID-19, brain fog, social isolation, disinformation, all these things are plaguing us, right? And on the right, you can see the results of this. So this is serious stuff. We argue with brain capital that the way that these brain and mind issues are being coordinated across government is just not working, right? Because they're in many ways not being coordinated. We have education sitting out there as a puzzle piece, mental health. We all know that there are like ministers that look after all these different things, and bureaucracies, sometimes they talk, but mostly they don't, all the way through to the effects of climate and pollution on the mind and such. So this is all fragmented. So how do we unfragment and put this puzzle piece back together into the whole, into a whole? We need a next generation brain strategy. We need to think about new ways of doing it. And Joe presented a wonderful exemplar, and I'm talking about the industrial strategy now. So the industrial strategy, think of it as like setting up space tech. We're setting up the space tech industry, but it's called the brain capital industry. Space tech is just a constellation of technologies that's put under an umbrella, right? It's rocket engines to satellites. That's all space tech. But if you formalize something, you can get governments really interested. You can get governments to entice private sector. You can get the private sector to work with the government. So you can rally public-private support. And now we see space tech is huge, right? And we see, for better or for worse, private sector billionaires getting involved in it. So that's the kind of thinking about this industrial strategy. We have 7 different elements, and I'm going to go through them individually now. First of all, we need to start with what is brain capital technology, right? So I want to, all of you in the room are involved in different parts of this. We have our Aussies down the back in early childhood brain development, Michael, Sally, and Karen. We need to think about late life and longevity technologies like Scott, what you're doing with determined health, brain performance, education. All these things are brain capital related technologies, right? So I'm saying that like space tech, this is the brain capital industry. And it's very heretical. Maybe because I'm Australian, I'm just going to be bold and just say this stuff. So I look forward to constructive criticism afterwards. So this was what I was saying. It's literally we're just following what we learn from space tech or like green tech. Green tech is nuclear reactors through to solar panels through to wind farms, right? This is the same kind of thing. And who would have thought that we'd all be talking about industrial innovation policy today? But that's what I've been nerding out on in the last maybe 6 months. Important as well beyond the technologies is linkage to critical infrastructure. So this is like what my friend Kwasi said, the liquid space between technology and buildings, right? So this is what we need to, if technologies don't solve everything, we know that. How do we link in with schools, universities, hospital systems, things like this? How do we also think about engagement with nature and the built environment in that sense? Financial innovation is critical. There are many financial wizards in the room here that are thinking actively with us about how do we advance this work beyond venture capital to venture philanthropy, public-private partnerships, impact investing. It's important that we inventory all of these opportunities and think about which ones fit for which part of the industrial strategy. This industrial strategy will probably manifest dozens of organizations we don't even know about yet, and we've just launched it on Thursday. So maybe we'll see funds and different things going on in all these different areas. Watch this space. Of course, the workforce is critical. If we were to mobilize and say we want to have $1 trillion brain capital technology industry in 10 years, do we have the workforce for it right now? Can the pharma companies and big tech keep, do we have the workforce? We really don't, right? So that's when we think about universities cranking out next generation entrepreneurs that understand neuroscience and understand the process of translating science to clinical, to policy, and into business. So we need a workforce that's brain healthy, critical thinking, AI literate. We need to think about lifelong education. So that's kind of an interesting part of industrial strategy. It's not just the technology, but it's how do you actually fuel the technology with the right workforce that can engage in private companies, nonprofits, etc. Missions are important. Jonathan, you mentioned missions for what you're doing at Harvard. These missions are terrific, right? Think of the Apollo mission. We wanted to get to the moon. That's a mission that has a defined endpoint. We had a certain amount of resources and we did it. Could we think of missions in, dyslexia? I know the Californians are thinking about missions in dyslexia. We think about, missions in depression, like Jonathan, what you're doing. Can we reduce depression by 10% in 10 years? There are all these different types of missions that we could think about. We need more than one mission, right? We need to have precise different missions, and that's the way we can rally public and private. The public sector alone won't do this. It needs a mixture of both. We, of course, need coordination within government. So we've been thinking a lot about how would you govern this kind of new industrial strategy? What would the White House do, or what would the European Commission do? So we need to think about, AI, responsibilities, business and law, education, neuroscience, and health. We're thinking in the US about OSTP, Office of the President of the United States, and DHHS. So it's interesting to think about how would you actually govern this. This is a form of statecraft in a sense if we're really trying to rally a big industry. An industrial innovation industry, as I said before, technology doesn't solve everything. Sometimes technology can make things worse, right? So we need to nest this innovation strategy within a broader policy framework. This is almost like a post-industrial strategy in a sense. We've written, many of you in the room have been involved in these papers about the role of brain capital in sustainability, food in the brain, youth affairs, democracy, economic security, and neuroshield. So happy to talk to anyone that's interested further about these things. So what could this strategy mean to you? What could it mean to your organization, to your country, to your state? What could it mean to the United Nations? It's an interesting question. What could it mean to your investment fund? We need a coalition of the willing for this, right? Over the last 3 years, we've built up the Brain Capital Alliance as a great coalition of the willing, very transdisciplinary. So what role would you like to play and help us to achieve this? Because this is big and bold, and it's very audacious, it's very risky, but we need to work together as a team. So thank you very much.
Thanks a lot, Harris. And with Joanne, we were debating whether the Pentagon was intended in one of your slides. But without elaborating on that, or probably we need a glass during the reception to discuss this. I'd like to call on stage, without further ado, Dr. George Vradenburg from the Davos Alzheimer's Collaborative. George, I don't know if you have slides, but otherwise you do. Okay.
I do. We'll see it on. You have make sure the slides.
Okay.
Those aren't mine.
No.
Do I have
have slides.
You should
have my slide.
Okay, let me see. Is that whose slides? Whose slides? Okay. Yeah.
They may be out of order.
Oh, okay. These are yours. Okay. Probably. Yeah, but probably we changed the order. But maybe. Okay, George, can I ask you to sit down? Maybe I'll ask Hervé then to come in first with a word of apologies. I think we. Oh, but that would be interesting. Shall we? Shall we do that next year? Yeah. Okay. Awesome. Okay. All right. Or maybe you ask then to present at the end of the day to figure out if you understood anything from what your colleagues would say. But okay. Okay. So sorry about this mishap, but maybe Hervé, I can then invite you to come on stage. Professor Hervé Chneiweiss from UNESCO, the International Bioethics Committee. And Hervé is going to talk to us about the European Charter for the Responsible Development of Neurotechnologies. So, Hervé, over to you.
Thank you. So we are going to see if these are my slides. No, it's not the first slide, at least. So is it possible? No, we can jump to this one. To articulate with what Harris just said before, nothing will be possible without building trust. And we need to think the various ways to build trust. And what I'm going to present to you about neurotechnology is a real questioning about what means trust. Trust between scientists. We need absolutely to know if what we are developing is the right things. Trust with the public, trust with investors, trust with the governance. So you will all agree that our brain and our brain activity is raising what we are, regardless of gender. We spoke of women and men, regardless of our culture, religion, from what we were. And it's clear that this brain activity drives our possibility of autonomy, thought, privacy. And we now have tools that we name neurotechnology, and at the OECD level, we gave a definition of what we mean by neurotechnology. Let's say that collectively it's the device and process that allow to read the brain, to detect what kind of activity, and the various processes that allow to modify the brain. Certain of the system allow both brain-computer interface, for example. So all these systems that access, monitor, study, evaluate, and in certain cases modify our brain activities. And in the recent period, we had wonderful ways, either non-invasive, like the EEGs that you know, or invasive, like chips, and you most likely saw a couple of weeks ago these wonderful works of several teams, these two illustrations of these implants that allow brain to voice systems that allow 80 words per minute, which means speed, higher speed than I am speaking at this way, with an incredible vocabulary. Obviously, this is invasive with implants and chips, but let's say that in the next 10 years, it will be less invasive. So on one way, it's wonderful. Since this morning, we are speaking of the burden of neurological and mental disorders, and it's going to be part of the solution because it's going to solve these questions of people losing their speech after a stroke or recovering some autonomy by this work. Since I am coming from Europe, I illustrate with the work of Grégoire Courtine team in Lausanne, these people that are this guy who is able to walk again due to a brain interface machine between the brain and the spine. But on the other side of the coin, you also have the possibility now to interfere and question the notion of identity, physical and mental integrity, the question of autonomy, the social question of decision making. And we see some actors that clearly are not coming in only for health. You know that DARPA invested more than $2 billion in different neurotechnology process. And a lot of investors like Facebook, now Meta, Kernel, Google, Neuralink are entering the games with billions. And clearly their options are to use, for example, brain-to-text to remove the keyboard of your computer. So at the level of OECD, we elaborated between 2015 and 2019 a set of recommendation. In parallel was a recommendation for AI and a recommendation for neurotechnology. Clearly, OECD recommendations are non-binding, but as soon as they are adopted by the various governments, there is a commitment to implement and to develop something to make these things practical. And there is a process of survey after 5 years to see how the various countries developed their proposals and developed the implementation of the recommendations. So to go quickly, because you can find this on the website of OECD, and you can find in the details, because here I am giving you the 9 principles, but each of these principles has several sub-recommendations to implement these principles. You have some principles that concern proof of efficacy, safety, but also a principle of inclusiveness, principle of public engagement, how we develop. To answer to some previous questions, enable the capacity of oversight and advisory body. We heard about the slow aspect of some of these advisory body or agencies. Safeguard personal data, and I'm going to come back on this question of safeguarding personal brain data and information, because clearly this is the main breach to your privacy. And promote culture of stewardship, trust in neurotechnology. And finally, but not least, anticipate potential use, misuse, or malignant use of the technology. So you see the positive aspect, but also the monitoring and overseeing aspect and the potential deleterious aspect of the technology. So coming from that, at the level of the French system and with support of the French government, we started a process gathering the various actors. Gathering the various actors, you will see it means obviously the academic sector. I am a guy from Sorbonne University, and I am a physician at La Salpêtrière, so the public sector was involved with research organization, but also the private sector, the biotech, and the patient association, and also professional association. This was a 18 months process to raise a text, a charter with engagement. And this engagement starts by recognizing what with several colleagues we could name neuro rights. Neuro rights are not, in my view at least, and as I was a chairperson of International Bioethics Committee, you can go to the report 2021 on ethical issues of neurotechnology that we published. Neuro rights are the right to the freedom of thought, the right to liberty, the right to autonomy, the right to cognitive liberty, and to mental integrity. These are basic fundamental rights that we need to protect from any abuse and any malignant use. So the 5 elements of our charter is the first engagement of these various actors to protect, personal data. Various actors, because it's true for the public research, we need the data to develop new knowledge, but it's true also from the private company. How a user need to how, on a way that is clearly explained, how with an accessible and rigorous information, how the data are going to be collected, how the data are going to be processed, how they are going to be stored, and if any use or reuse of the data, how it could be. And this clear information needs also to mean that you can refuse sharing your data, or you can limit the use of your data, and you directly or through a third party, you should have access to what is done with your data. Second principle, to ensure the reliability, safety, and security of the medical device. Obviously, you need that the products are safe, but you need also to know that they are effective. I'm just going to tackle biofeedback, for example. As a neuroscientist, I hardly find any proof of efficiency of neurofeedback. You need also to ensure the reversibility. We have the dramatic case of GeneSight with these 300 people with the chip remaining in their eye. And we need also to have accounts and feedback of patients and users. The next principle is to have an ethical communication, no overhype, unrealistic expectation, but also no specific fear. It's not because it's neurotechnology that we are going to become cyborg, for example. Maybe some people would like to become cyborg, but this is a discussion about transhumanism, and we are not going to start a discussion about transhumanism in this assembly, or later with the coffee break. We absolutely need scientific evidence. That's the second time I'm speaking of effectiveness, but scientific evidence. And we need to have some kind of transparency about the kind of algorithms that are used. The next principle is, the last principle is obviously to prevent malignant use, abusive use, and for example, if it could be used for intrusive surveillance, it's something we would like to prevent. At the various age, you know this, you have seen these images of kids monitored with EEG to monitor their awareness or their attention. It was an American company making the trial in China, so this is also something that could be challenging on an ethical point of view. And we need to be able to monitor the various applications and, for example, to prevent any use to influence, to bias your decision and decision-making process. Finally, we absolutely need to have this device fulfilling societal expectation. What are the real needs, and what will be the real user? We don't want to develop tools to create a new class of enhanced people. So we need absolutely to promote inclusiveness, to fight against any kind of discrimination. It's not because we are using model of the brain to develop some tools that we want everybody on the same way, how we respect diversity, how we respect, for example, kids with the autistic spectrum or with deafness. We need absolutely for that a societal dialogue, and we need to guarantee that all people that will need the tools to access to these tools. This is the question of the cost of innovation or innovative products. How are we going to make this available for the people that will need it? And obviously, because we are also in Europe and after the COVID, special attention should be dedicated to mental health era. So as you can see, about 25 signatories already in the French Charter, and the interesting thing is that you have the research or academic organizations such as INSERM or CNRS. You have professional organizations, the Society for Neuroscience or Cortico, who is people developing neurotechnology. You have the private sector with several companies developing biotech tools. You have the patient association, Parkinson patients, Alzheimer's disease. And you have governing agencies like the biomedical agency, which is in charge of some surveillance of these technologies. So we gathered various actors. And obviously, now the challenge is to move out to a larger scale. And with the help of EBC, and we like to thank Frédéric as a main actor, with the help of FENS, Federation of European Neuroscience Societies, with various partners already engaged, such as Parkinson Europe, also the European Federation of Neurological Association. And I hope as many of you that will join us in this new co-construction and new elaboration, and we have also some international partners. Canada is going to join also now. We'd like to move to the next step of this charter and make it international. Upon any kind of request, it's at your disposal. Thank you.
Thank you very much, Hervé. And actually, I can make a slight word of self-promotion by saying that we will have a first roundtable. A first roundtable on this issue at the Brain Innovation Days in Brussels, end of October. Actually, it's to explain the reason why EBC, and once more re-emphasize the reason why we have convened this event today, and also maybe to explain the commitment that we would like to make to carry on this collaboration for the future. And it's basically to work on the basis of what you heard already today, and which I hope is not coming as yet another terminology, but which is the European Brain Health Partnership. So that's something that was in the making since a couple of years, and which actually is going to start at the horizon of 2025. So that comes in the second half of what is called the Horizon Europe program. So it's a program for innovation and research at the European level. And all of this was stemming from another initiative that EBC was involved into and coordinating, which was called the European Brain Research Area, which was basically to strategize the vision for brain research at the European level, but not only doing that for IBRA partners or for the EBC community, but really making sure that these objectives were responding to societal challenges. So since 2018, we've been presenting this work and basically instructing our colleagues around the world from the developments related to the development of the EBRA agenda, the activities, and the strategic orientations. And this was peaking with last year's participation in the UNGA 77. We had a roundtable to present the outcome, but also an encouragement to carry on this engagement at the global level. Hence followed a March conference during the Brain Awareness Week. We were last week in Grenada to present at the European Brain Research Organization, where we had a session on fostering global dialogue, and this is the reason why we're here today. But more significantly is that the Brain Health Partnership is under preparation as we speak, literally, as we are starting a new funded program on the 1st of November with national agencies for research into the brain in Europe. And what we are basically going to work on is the preparation of the governance and the orientation for the partnership at the horizon of 2025. So we work together with 17 other partners, which will represent, as you can see, a number of different countries, which are probably the most committed to those objectives in the context of this co-construction mechanism. And you heard from the representative of the European Commission earlier that this exercise was very much looked forward in the relation of establishing collaborations and establishing also commitments from a certain number of partners and a certain number of member states. So EBC specifically, and I spared you the complicated graph of everything that the partnership is going to aim at, but we can provide you with this information, I should say, offline. But we will be involved in the agenda setting, as I mentioned, but more importantly to us in this notion of global outreach. So making sure that we maintain, let's say, this connection with, everything that is being done around the world, and making sure that it resonates and that we can build upon that in order to establish collaboration is very much what is in the DNA and in the spirit of what the EU is aiming at the moment. So identifying international initiatives to be included or organizing outreach activities will be part of what EBC is going to be tasked to do. We've identified a number of opportunities in doing so. It's starting actually today, but we'll have the Brain Innovation Days that EBC is organizing now on an annual basis. In October, you're more than welcome to make it. We plan to be present at the SFN meeting in November. There will be the Brain Awareness Week on a yearly basis and further UNGAs. We'll come in a moment to the panel that will be moderated by Ines and Magali. And on that occasion, I think it's very important that we emphasize why UNGA 79 and why UNGA 80 are going to be very important momentums in our road ahead. We already alluded to the Summit of the Future that is going to be organized next year. I mentioned 25 as being one of the dates of our horizon, but you heard in the context of the Global Action Plan on Epilepsy why 2030 would be important at the global level. There is another reason for that, is what I think Harris mentioned, are the Sustainable Development Goals are going to come to an end. And next year, in 2024, the UN is going to think and establish what is going to be the metrics to guide its action beyond 2030. And that's actually where we should be landing, hopefully in the course of our discussion, and how we can feed into those discussions to make sure that we have our say, bearing in mind that in the SDGs, there is nothing about research, there is nothing about innovation, there is nothing about science. And hence the contribution we'd like to make as a community to the Science Summit that was organized on the occasion of every single General Assembly of the UN since then. So this is extremely important, and we'll come back to that in a moment. I'd like to thank you for your attention. And maybe I would suggest that we move on to the discussion on brain health. Or George, if you'd like to make your contribution, bearing in mind that we are a little bit in despair of finding your slides. I'm very sorry about that.
I'm glad I didn't do your slides. So let me, I'll be, as Henry VIII said to his second wife, I'll be brief. I have been very humbled and inspired by today. Humbled in the sense of the extraordinary amount of thinking and energy that's going on, inspired by the breadth of thinking. I am probably the least qualified to speak here. I am a lawyer by background and training, coming out of media, entertainment, and the internet industries. But I have 3 generations of my family lost to Alzheimer's. A grandmother who died of what they call senility in the late 70s, a mother who died in the early 90s of what they called Alzheimer's, but was probably Lewy body disease and misdiagnosed, and now a brother who is in the late stage of Alzheimer's. And it is quite clear to me that this disease, if we do not make faster speed in the next 45 years that we've made in the last 45 years, it's going to hit my kids and my grandkids. And so this is now a passion project for the rest of my life, which is devoted to this. I founded a U.S.-based organization called Us Against Alzheimer's, which is sort of a venture philanthropy and a patient advocacy group. We work very hard with our Congress to give Walter all his money, and he's been doing a good job with it. We also formed something with the World Economic Forum called the Davos Alzheimer's Collaborative. This is an effort to tie together at the global level, the way we have with Gavi and CEPI in infectious diseases, global efforts to get at Alzheimer's. Now, we've had a big year this year. First, traditional FDA approval of a disease-modifying drug in Alzheimer's, the first in history of a disease identified in 1906 by Alloway's Alzheimer's. So we have started. So in the history of Alzheimer's, as they write the books, 2023 will be a big year. But already we have to think not only just how to get that to patients, as a number of people have described, but we have to think about what's next. So we already have a working group on Alzheimer's vaccines with the idea, regulators, NIH, Walter participates, and 8 companies who are working on Alzheimer's vaccines. And with the goal by the end of the decade to get an Alzheimer's vaccine, an active immunotherapy into patients in a secondary prevention context with the path towards a primary prevention. So we have just started. Now, number of statistics, I'm going to recall the opening discussions from my HME about the cost of this disease. The 1.3 trillion, although there are other numbers, but 1.3 trillion estimate for the cost of Alzheimer's annually. That's an annual number. Over the next 10 years, as that annual number is going to double by 2030, the decade costs of this disease are going to be $15 to $20 trillion. So this is itself a big disease, let alone mental health, which is comparable, if not greater, in terms of cost. So these are big numbers. The estimates today, about 55 million people with a diagnosed form of Alzheimer's or related dementia. But that's only the people who have symptomatic dementia. If you look at the pipeline of people that have the underlying toxic proteins of this disease, it's a number that's 7 times that. So the number of people in the world today with symptomatic or pre-symptomatic disease is already at the 400 million person level. That's going to triple in the next 30 years. So we're talking about over 1 billion people with either pre-symptomatic or symptomatic disease. Now, in a sense, that's an awesome number to think about. But it also gives us a window because there's 20 to 30 years that you have this disease before you actually get the symptoms. There's an opportunity. Can we find the therapeutic or non-therapeutic interventions that actually can prevent the symptoms from ever occurring, slowing the disease down, stopping it? HIV, AIDS was that example. We have not gotten a cure for AIDS. We have gotten no cure for HIV, but we are able to keep people who are HIV positive from dying of AIDS. That's the strategy. So the 2 drugs, the 1 drugs that have currently been approved in the United States, and the second one we hope to be approved by the end of the year, already are in secondary prevention trials, in patients who have no symptoms of the disease, in order to slow the disease down so that you defer the onset of symptoms. The other strategy, obviously, is the risk mitigation strategy, which we've talked about, which is whether or not can you intervene with a variety of behavioral interventions that can, in fact, slow down or prevent a significant number of people getting symptomatic disease. I won't talk very much about that other than to say that we have now in our U.S. organization an effort to work with the business community on how to define, how to change behaviors. Because I believe that my business community in the United States or around the world is more likely to change my behavior than the United States government. Excuse me, that's a libertarian comment, but I just think that, in fact, as employers, we've been asked to create a brain health scorecard that will be used by businesses to say what things should business do to enhance brain health, brain capital, or other ways of characterizing what business wants, and then associate those companies that adopt that brain health scorecard with better company performance in the stock market or in the competitive marketplace. And then I get spun off on Harris Eyre's, sort of fantasies. Do we create an ETF to invest in those companies who have done those brain health things, and then begin to get more capital built into the business sector that in fact adopt these kinds of practices in companies. So there are a lot of things that Harris Eyre has inspired me with. He always stretches my mind further than I probably am capable of recognizing. Now, what do we do? The DAC, Davos Alzheimer's Collaborative, DAC to its friends, basically is saying, what's the system of getting research to trials to people? So that's research into trials, that's trials into regulatory and enabling processes of governments around the world, and then it's actually reforming delivery systems around the world so that they actually deliver these new therapeutic or non-therapeutic interventions to people. That system has to be linked and scaled at the global level, because guess what? The number of people with Alzheimer's around the world is very small percentage are in Europe and the United States, which is basically all we hear about. Most of the people with Alzheimer's in the world are in low and middle income countries. And I don't believe that in fact the intellectual capacity of the world is 90% in Europe and the United States. I think there's an intellectual capacity and a contribution to be made by low and middle income country researchers in cohorts around the world. So we invest in those cohorts to themselves gather the cognitive data and the blood data that will give us biomarkers and genetics around the world, and then link those into massive data sets that are now being developed with the Gates Foundation and Gates Ventures to be able to enable the researchers around the world to do that. What we found by doing and linking these cohorts is that in fact some people around the world are actually looking at the same problem. The effect of climate change on brain health. Well, it turns out that Chile is doing research on that Colombia is doing it in the Amazon, and that Kenya is doing it in Africa. So we begin to link those cohorts in a common effort and then talk to philanthropic funders who are interested in that topic. Second, retinal scans. We cannot diagnose the people around the world with the big PET scans. We don't have radioactive machinery that will feed these PET scans around the world. PET scan equipment is very dear, very scarce. Well, retinal scans, turns out that retinal scans, eye detection of beta amyloid, is prevalent. So in China, in Malaysia, in India, in South Korea, in Latin America, and in Africa, retinal scan technology is in fact pretty prevalent, and we may be able to use that to diagnose these diseases. And what does that mean? Now the retinal scan manufacturers see that there could be a global market for their new diagnostic techniques, so that in fact they're now investing more heavily in advanced retinal scanning technologies. Risk mitigation. Turns out that meditation around the world, it's sort of a popular thing on the West Coast and some places in New York City here. But in fact, in India, it is built into the culture. It's built into the culture in Muslim countries. So you begin to link those cohorts that are working on that risk mitigation factor for stress and for anxiety, and the ability to detect or to introduce and to scale risk mitigation factors around the world is quite amazing. Clinical trials, we've invested now in a transatlantic trial structure, but we're working now with Worldwide Fingers, which is a risk mitigation intervention strategy. They're doing trials that are a combination of generic drugs, metformin or an antihypertensive, together with risk mitigation behavioral lifestyles. So we have connected to that network, and we're doing that with them. What it says is that we do have now a global mechanism to do this. We now need global funding. And we have had the G7 in 2012, the G7 in 2023 said they're into this. They want to do something. The G20 has said it. The WHO has said it. But in fact, we do not have a global funding mechanism. We need it. We need a global mechanism for change, and we need a global funding mechanism. So I hark back to the initial presentations on the cost of this disease, the degree of human suffering that is current and will occur as a result of this disease, and say we need global mechanisms that bring together every single sector of society. And since I'm a patient advocate, I want to bring together governments and industry and researchers and other patient organizations because patients can drive this. They're the moral force behind change here. We as patients need to organize, patients need to convene to make sure all the players with their differential incentives on what they do are motivated to serve us. And that's the message I bring to you, and that's the way I want to work with the European Brain Council. Thank you for having me. I appreciate it.
Thank you, George. That was extremely compelling. And when you started using the acronym DAC, I thought you were meaning like an index, like the CAC 40 in the Paris stock market. So maybe that's one of your next activity, having a DAC 40, and see how companies perform using your scoreboard. So without further ado, I'd like to invite other friends and colleagues of EBC, Professor Ines Jabapouwa from the Brain Health Nexus. You're the executive leader. I think, Ines, you have introductory slides, or should I bring Magali on stage as well immediately? Or I can introduce Magali, who is going to join us in a moment, but Magali is the founding chair of the Brain Health Nexus and CEO and president of the Cohen Veteran Bioscience. So please, the floor is yours to moderate the last session.
Where's Magali? There you are. That's great. I'll just make sure we queue up the slides. Great. So this has been an amazing, inspiring day of presentations and discussions. And now as we close the agenda, the key question before us is, how do we move from recognizing the many efforts that are underway to advance brain health into concrete collective action so that we're left with something tangible that we can all think about for the next steps of these initiatives? I thought it might be helpful to begin with providing a summary of what I saw as the key takeaways from this meeting. We're gaining a more accurate understanding of the burden of brain disorders and the variability across countries. With that comes the responsibility that we need to have data that is more inclusive and reflective of different countries and different communities, something that has been recognized today as a real lack. There's also a growing recognition, however, that brain health is more than just the absence of brain disease, and that's what we want to achieve for all citizens of the world. There still exists a divide between neurology and mental health, with no consensus definition at this stage of brain health. However, we have an excellent starting point with the World Health Organization's definition, and we all need to move together around some alignment about what we mean when we use the term brain health and when we convene people around brain health. Are we speaking the same language? A better systems-level understanding of normative brain function and the common underlying mechanisms across brain disorders will help us to unify silos and accelerate progress. I think Angela again said if we can solve ALS, we will have solved likely other neurodegenerative diseases. And that's the thinking behind our understanding at the systems level of diseases and commonalities that cross different diseases. Brain capital is a powerful concept which is aligned with the shift to the brain as an asset and brain health for all citizens benefiting society, the labor market, the economy. But to translate this concept into action, we need to correlate economic measures and brain health measures. And George touched on that a bit to say that we need to figure out how this tells the story of the impact on businesses and their bottom line and why it's so important for them to become champions and advocates for brain health. There remain significant challenges to understanding the brain and addressing the burden of brain disease around the world. Walter Korshets talked about the massive investments that have already been made in the US, and yet he said there's still about a 1% understanding of brain function. It's not just a money challenge, but in fact, the challenge is much more about the complexity of what we're dealing with. However, advances in data science, systems modeling, simulation, AI analytics, and neurotechnology, which were discussed today, have created new opportunities to accelerate research. But this has to be done with ethical, social, and legal implications considered. The pathway from discovery to people is not linear, and the engagement of end users must be at every stage of the research process, from setting priorities to design, delivery, and monitoring. We heard a really compelling presentation by a lived experience advocate, and I can't emphasize enough how important it is to bring people to the center of these discussions. Otherwise, it just becomes an intellectual endeavor, and in the end, you don't really make advancements to mankind thinking solely on an intellectual level. So the people part of the equation is really important. Enhanced multi-sector engagement in the brain ecosystem is needed to foster dialogue, to exchange knowledge, accelerate investment in research and innovation, and facilitate treatment and cure development. So there's no question we are all aligned around the fact that more collaboration is needed. But I think one of the points that was made by John Ney was that we need to think differently about how we do research. So we need to stop thinking of it in a very siloed way, but new types of collaborations, of maybe bringing people together that haven't traditionally worked together across disciplines, across institutions, across countries, and foster new approaches and new thinking to the way we've always done research. And finally, there are many excellent local, regional, and country programs and initiatives underway. A global collaboration will enable us to scale the most meaningful and impactful innovations, and also to build a new initiative that links data and knowledge. Last year, I had the privilege of presenting the Brain Health Nexus, which was initiated by Cohen Veterans Bioscience, and specifically by its CEO, Dr. Magali Haas, who's here. The mission of the Brain Health Nexus is to build a new paradigm of collaboration and unleash science and technology to optimize brain health and prevent brain disease. And what this does is it flips the script from a deficit or healthcare model to an asset or health promotion model, and that changes the way we think about the value of brain health. All of us here understand that brain health is not just a health issue for those directly impacted, but it's an issue which affects us all. And yet we ask ourselves, why haven't we made meaningful progress in understanding and optimizing brain health? We saw a bit today about the various barriers that we've encountered, and we ourselves did a broad-based consultation. And these barriers resonate with some of the points made, but the more important point, I think, is that there have been many more opportunities that have emerged. And they're led by science and technology advances, and most recently, some of the power of generative AI tools like ChatGPT and GPT-4. A mindset of global collaboration. George Vradenburg talked about what's happening in the Alzheimer's space, and I think that's a shining example of global collaboration. And investments by governments, by philanthropists, and VC investors. So while we talk a lot about the need for more funding, and certainly that is a key part of this story, we should recognize that there has actually been quite a bit of investment, and now the goal is how do we connect and link all these efforts. This is the context in which the Brain Health Nexus first emerged in 2019, and led by Magali, a founding steering committee was recruited, including the past president of the European Brain Council, Wolfgang Ertl, and Harris Eyre, if he's still in the room. And the goal was really to set the vision of how we make a meaningful contribution to catalyzing and accelerating local, country, and global efforts to optimize the brain health of every citizen. The deliberations of this committee were complemented by individual interviews with thought leaders, a literature review, and an extensive broad-based consultation with the ecosystem. This led us to the goal of developing, validating, and driving the adoption of a brain health index. The concept of a brain health index is not novel, but why is it so important? Well, it's important because that's the pathway to operationalizing brain health. And Greg Roth made that point that if you don't have tools and metrics, it's very difficult to see how you're doing in terms of assessing brain health and then assessing it across a lifespan and across populations. There are examples of other indices, that are in play. We just heard about another one with the Brain Care Score. Most of these are actually focused on later stage, so cognitive decline later in life. Some of them measure the risk of developing dementia, and they don't really look at overall brain health. There are some that look at a wider time period, but they're mostly cognition focused, and they're geared towards brain training and enhancing performance. And most important, they don't really address biological mechanisms. And the goal is not to displace these indices, but to work towards arriving at a consensus of objective and subjective measures of brain health, and then developing a scalable common approach to building the evidence base for quantifying brain health. I'm going to pause to now recognize that it's Magali Haas and Dr. Sean Hill who were the key architects of what we've developed to get us to a brain health index. And our main premise here is that brain health can be first defined and then quantified at an individual level through a combination of measures based on core domains of brain function and an information technology framework that collects, stores, integrates, and models global data. These measures would be the basis of an index that would have the same benefits, we hope, as a heart health index, which really changed the paradigm from looking at disease treatment to looking at monitoring risk factors across the lifespan, thus preventing disability and death, expanding the quality of life and extending life. And using a federated model of clinical research, we can augment digital health measures with insights derived from genetic, from imaging, and from other innovative biotechnologies across both healthy and diseased populations. And with the advent of powerful AI and analytic tools, these data can be combined and used to build models that predict health status. As we move to the next stage of the Brain Health Nexus, we'll be driving an ambitious work plan. And the index itself will be backed by an innovative approach, an open source app prototype. And this approach will allow different stakeholders to freely brand the app, fostering universal adoption and dedication. The open source nature will enable accessibility, adaptability, and transparency, and white label branding will offer stakeholders the flexibility to tailor the app, ensuring wide acceptance of it. In the next quarter of the new year, we are going to be holding 2 workshops with our first Canadian partner, the Ontario Brain Institute. The first will focus on governance, and we heard quite a bit about governance today and the need to develop a better framework if we are going to be sharing and storing vast amounts of data. So the first workshop will focus in this area, and we have set a number of objectives that we want to achieve. And this will be a small gathering, but we will be looking for people who are interested and expert in these areas to participate. The second workshop will focus on telling the narrative about brain health. So how do we define it? And then what are the measures, and what are we actually measuring today that we can use to build the first brain health index? And these are some examples of some of the measures that we may be able to look at. So they include quite a number of things, and sleep was mentioned earlier, that provide us with enough evidence that we see is already being collected that we can start to build this first generation of the app. And finally, we know that it's going to take a community of collaborators coming together, contributions of different communities at every stage in the development, validation, adoption, and deployment of a brain health index. And to advance this model, we need funders, partners, scientific expertise, lived experience perspectives, and champions. And we need everyone in this room today to look at how we build an international coalition to develop this Brain Health Nexus and the index. And these are some of the partners with which we're now having conversations, and we've been working since last year, and so we've made a fair amount of progress in moving forward with our vision. And finally, we see this potential for a brain health index with the interplay of detailed physiological measures, the flexibility of this open source white label branding, stringent data governance, and the unifying potential of an index, we think we can herald a transformative phase in global brain health research and in collaborative endeavors. Thank you.
So the point of this session is for us to actually have an interactive discussion. And the first thing that we have to be thinking about is we've all been here all day listening to a number of initiatives. We all understand the gaps that we're facing, the dire needs. And this is a discussion that we launched last year as well with the first inaugural meeting of this kind, where we had half the people in the room. It's very exciting to see quadrupling of the numbers. But the question that we have to ask is, we all want this to happen. Why doesn't it? Why doesn't it? What is it going to take? I'm not going to give you the answers. I want you guys to raise your hands and start out and start giving us some thoughts about, there's a reality here, because I've been in this business for 20 years. Many of you are my colleagues in this field, have been having this conversation with me for 20 years. And yes, some of it was about a lack of the technology. Some of it was a lack of understanding of the gaps and the needs. But in fact, it seems like it's something bigger than that, right? What does it take to drive collective action? Anyone?
So I guess that if no hands gets raised, then we are going to point people, but we are lucky enough to... Whoa, 4, whoa. Jeffrey, you're first.
Jeffrey Avila from Malaysia. We are divided because we are different race, different religion, different gender, different country, different political views. But most importantly, money, funds. We say in Southeast Asia, no money, no talk. So, if you don't have the funds, you don't talk, because you just talk and nothing happens. So I think we need a leader. A leader can be a person, can be an entity that is trusted by all countries. A leader like United Nations is trusted by everyone, even all parties with the Congress trust United Nations. I'm not talking about Russia. I'm talking about. So I think with that leadership and trust and funds, things can move on.
Fantastic answer.
Following up on the same point, I'd say maybe what's behind the money, it's actually the incentive structure that we have. I think that is one of the major issues. Now, not to be too controversial, but many of the organizations that are here today are doing overlapping work. That is because spinning an organization is something that we have an incentive structure for, and spinning a company and spinning. So I think one of the things we need to work on as a team is like, how do we create an incentive structure that is more socially oriented instead of individualistic, right? And how do we do that with the funders, and how do we do that for us? I'm still mid-career, I need to do my next steps, and how do we deal with that part that whether I want to do some good because I want, but at the same time also have my career going. So I think incentive structure, it's probably one of the elephants in the room. Is it an elephant or a gorilla? I never remember, but it's one of those.
Thank you.
So I certainly agree with the comments that were just made, especially about resources, but also I wonder whether, as we think about, Brain Health Index or even the concept of brain health itself, and maybe I'll get thrown out of the room for saying this, but in a sense, we're also taking a step backwards, because when I think about what happened with cardiovascular disease and how it took many, many years and a lot of people pushing to get stroke added into the construct of cardiovascular disease, it used to be all about risk prediction of MI and sudden death. And, a lot of people pushed to add stroke to the equation and get that piece of brain disease in there. And I wonder if, the goal there was to make it about all of cardiovascular disease and have a more holistic definition of health. And so as we think about only a brain health metric, I'm wondering why we're taking a step back there. Any company or nation or anybody who's going to try to measure, the health burden or the disease burden or the health excellence of an entity is going to be looking for more holistic pattern of health. And so I would just encourage us to think about other aspects of health in whatever metric or approaches we take, so that we're not taking a step backward and only focusing under our, lamppost, if you will. And, just as an aside, I would say it's interesting to me that at this meeting, for example, I'm here representing the Heart Association, but I'm actually a neurologist. There was one cardiologist. I don't know if Greg Roth is still here. I think he's the only one. Maybe there are others. But, there are people, like, we don't have the people representing those other areas, perhaps, who we should be inviting in, because we're not going to succeed at what we want to do. And what we're trying to do here may not even be as big as what we want to achieve, is what I would, challenge the group with.
I thank you for your comments. I do want to clarify that the Brain Health Index concept, as outlined here, is not just about burden or the outcome measures. It's about relating those to biological parameters that we can begin to understand the biological basis of these conditions. So the digital app is a tool for collecting objective measurements over time and longitudinally in individuals directly from the consumer, so they can be engaged in the process, and then hopefully augmenting that by bringing that app tool to multiple large cohorts that are available across the world, as we've heard so many times today, but where this becomes a common set of data sets that all of them can cleave to, or connect their data to, ultimately helping us to understand the biomarker components as well. So it's about the biological understanding of disease, not just the burden of disease. So a lot of the work that's already being done is really essential to relate those things to the economics, to relate that to those outcomes and endpoints. But thank you for making it clear. It wasn't clear.
My earlier question about incentives was already readdressed. But at the risk of adding yet another component to an already complex group of stakeholders in STU, I think that I don't know how many lawyers are in the room today, but law is a social determinant, I think, of brain health, because it creates these structures. And to the extent that we're talking about complex governance systems, we're talking about law. We're not talking about and to the extent we're talking about ethics, we're also talking about law. So I would invite more law and sort of law-focused folks into these conversations as well. Thank you.
Here's a comment over here. And back there.
Yeah, and try to follow the order.
We'll go around that way and that way. Yep.
I think this has been touched on a little bit, but I think there needs to be some sort of neutral knowledge broker that doesn't have a stake in where the outcomes are going to be determined. So, using the umbrella of the WHO or the United Nations that is inclusive, and also having principles that drive everything around including underrepresented communities, not duplicating efforts, those types of things. And if we start there, then the rest should fall out a little better. But my initial reaction to your question was, I think we are all overwhelmed by the need, and that that's partly driving the inability to solve it, is the overwhelming nature of the problem we're trying to solve.
Fair enough. Up here, back there, and then up here.
I think you got to understand that one thing, you have to integrate everything, all the data points. Once you are going with an app, there is no integration because data sets are lying somewhere else. So you have to design the entire ecosystem regarding the brain health. What are the portfolios? Who are the clients? what are the performances, what are the risks, what are the compliance in place. So once you start doing that, you'll have to address around 2 million or 3 million solution points to get to that. And under the matrix, you have to put all the brain, and then you can start covering. The second thing what I can feel is like there are many overlaps in the research part in the US. So same grant has been used by many grants has been used in the different subject, but they are only working on one subject. So that's the collaboration is the main here. That's what I feel.
I understand. Yeah, so one of the wonderful things about our mobile phones these days, the Android and the iOS systems, is that they do collect all of this data and have made it available for research purposes as well, but also as for app purposes, app building purposes. You can collect this data directly through these devices, and most people in the world have one or the other device. So what we have is this unbelievable tool at our fingertips for doing global research, right there. And we're not talking about making the perfect the enemy of the good. We're saying, let's start with the things that these devices already collect, determine which ones are the most important and relevant measures of and potentially relate to outcomes of interest, and then let's just start collecting it. And then over time, we'll understand what data are there, what data are not there, what compliance is there, what's not there in terms of consistency of these measures, and using AI tools to be able to start to understand where the gaps in our knowledge. And it seems, I know it sounds overwhelming and daunting, but we've been already doing studies like this ourselves at our foundation. I don't have, I work on TBI and PTSD to the point of neutrality, right? Like, I care about PTSD and TBI, but I'm willing to invest in this because I think we need to invest in this. It has nothing to do with my mission and has nothing to do with our priorities per se, but it has to do with the fact that if someone doesn't start it, it's never going to happen. We were able to collect sleep data right now very well. And there are other data like this that are available, and our colleagues, Sean Hill and others, have done the same thing at the Crumble Institute. It's viable, it's feasible, there are pilot examples out there. It's a matter of actually just starting and chipping away a little bit by little bit at the regional governance and all of these other issues that you're rightly pointing out. It's not trivial from that perspective. Yes.
What I had in mind, clearly throughout the day, some of the things that have been discussed indicates the disparities that exist. And most of these things that you're talking about can be tested in one location, but cannot be tested in other locations due to the obvious challenges in terms of the infrastructure, in terms of the cultural differences, and many different things. And one thing that immediately comes to mind is that for us to move as one unit, the global brain research community to move as one unit, we have to identify those things and then think about how we can work as one unit to help those that are behind to reach the level that we all want the research community to be. So from that perspective, we then need to think about what the community has discussed as the right approach that can be used in addressing their challenges, get it unified by different groups and funders, and then also follow that recommendation. So basically what I'm trying to say is that, for example, in the African neuroscience space, we have worked with the Wellcome Trust for 2 years, and we came up with a documented methodology on how best to support African neuroscience. And at the end of the day, I think Wellcome Trust did share the document with a few funders or not, I don't really know, but the document is there on how best to move up the African neuroscience to the next level. So what
Fantastic.
what usually happens is that you see these funders, saying, producing these calls, and these different organizations producing these calls. There are sometimes kind of conflicting with one another, and which may not develop the highest impact that we need to be able to move the field forward. So maybe what maybe we should take out of this meeting to help communities like ours, we need to go back to what, as a community, we discuss with different neuroscience societies within the continent, with different stakeholders, on how best to support our community. And then the other thing that I thought which really makes sense from this direction is when we talk about this issue of brain capital, I think this is something that can be used from the angle of even policy engagement in Africa to get them to appreciate the importance of brain health, because a lot of times, there is a poverty, there is this challenge and this and that, but the policymakers can easily see the value of something like this, and why, therefore, changing their directions in funding either science or neuroscience research or something has value. So from that angle, I agree with what you mentioned. If there is a unified body that represents the brain community, that engages with the government or policymakers or whatever, then we are likely to have a better we are likely to have success in our approach. Thank you.
Thank you. I think you bring up a really important point, which is that there are a number of existing very large foundations in this space, organizations like Simons and the Gates Foundation and the Wellcome and Co-Veterans Bioscience and others that actually have the means to support these types of things. But as you point out, we're all doing our own thing. And maybe if we can come together and collectively identify some clear opportunities, and maybe we can approach the World Health Organization and the United Nations collectively, and also with the lessons learned we've all had from our respective efforts, maybe that's the first galvanizing step. Thank you.
I'll maybe just continue in that theme, and hopefully this won't sound like a end of the day comment, but I think we need to be stronger advocates. I mean, when I think about the diseases and the people we're representing, I think the hardest thing is that we're representing people who often can't represent themselves.
Yeah.
I think about, in our case with ALS, what happens consistently is that we get incredibly dynamic people, and they have wonderful initiatives. I think back to the Ice Bucket Challenge, for example. They progress and they pass away, and their legacy often goes with them. You can say the same thing about virtually any of the diseases or challenges that we're all talking about. I think that's, I don't want to say unique to brain diseases, but it's certainly a really tough factor. And that means it's on all of us to be the advocates for people who can't be advocates for themselves. And as I think about the history of innovation in these spaces, I think what often happens is because the advocacy isn't as strong, then we're all left to say, well, we don't have enough funding. And then we end up, just disagreeing about, okay, where do we want to allocate this small amount of funding? I think we need to demand better. I think the people who we're representing deserve better. And so I'm incredibly encouraged hearing today so many different initiatives that are having real impact. I think we need to use those examples to say, this is what we can do when we're given a chance. But I think we need to keep pushing. And I think we need to say that, the sort of status quo of how brain health is treated is unacceptable. And these are global issues that affect everyone. So I think until we sort of get global awareness to that level, then we're going to be stuck talking about, how can we take the small resources we have and use them effectively.
So someone said earlier today, we're all just talking to each other, and we already all understand that problem. So how do we get that message out there? How do we advocate at scale?
I think, Magali,
I think that's your turn.
No, but if I may just echo what Justin said, because that's something we feel very strongly about at EBC, being an advocacy organization. But one of the plans, or what we encourage even our members in our constituency to do, is to say, okay, don't expect EBC to do the entire work for you. Of course, we're going to do our bit, but you should also take a stance and take your part in being the advocate of course, what you know best, but bearing in mind that you're connected to a broader ecosystem, a bigger community, and that it serves everyone's interest, and it will serve everyone's interest in making the pie bigger, rather than to fight for small pieces. So that's definitely also one of the reasons why we're here today.
Absolutely.
Okay, I had thought about this. So I thought about how to create something that can grow in terms of funding, answering to how do we create opportunities and, funding scales that scales with what the problem is really. And I think it's easy from that perspective, as long as the initial project is seen as a platform that then let other partners apply for additional funding. It works. It just, you don't have to do anything else, right? So the International Brain Initiative in the first, now we have a new leadership, Tony Annan in Australia and Judy Hills in UBC in Canada. Now they're starting to support satellite projects that are spinning off from the International Brain Initiative. And so they're providing letters of support that go with the proposal. This was not in the first phase, and this, I think it's a great potential for EBC, for any other organization, right? So what am I talking about? You're developing an app, and you probably need cloud technology around that app. There's someone in Texas that is expert in cloud technology. We can partner, right? You get your funding from Canada, and maybe organizations like the International Brain Initiative, EBC, can support the proposal with letters of support that state the importance, right? And then some of the funding goes from Canada to you guys, some of the funding goes through NIH to other partners. And I think the distributed model for growth exists, right? The model that we need is the model of partnership and support, right? So I think the funding is there, even though maybe it's not one program, it's distributed.
But I think what you're saying relates to what was said in one of the panels, is to really seek the alignment of strategies and priorities from the funders. So if we can coordinate amongst us and engage with them. I know that some were also commenting on the fact that regulators should be around the table, policymakers. But if we could start with the funding agencies and streamline their priorities, it would make a major leap forward. I'm very pleased you raised your hand, Declan. So I'm going to hand over, and I'd like to introduce you to another friend and colleague of EBC, but who made it possible for today. So one of the coordinators of the UN Summit, and who helped us organize the day today in this framework. So, Declan.
Thank you very much, Fred, for those kind words. Delighted to be here, and congratulations on such a very well thought through meeting. I haven't been here for the whole day. I've been sort of in and out in the afternoon, so forgive me if I've missed this or you've dealt with it already. But just what I'm not hearing is much discussion on policy making in terms of the mechanics of doing that. And of course, I've heard reference to the need for an enabling policy environment. But I really would encourage this community and other communities to, as it were, get into the business of policy making. And that is a whole art in itself, and that doesn't happen on its own. And that's a process of developing the evidence, designing policy. That's a broad principle. Now, with that in mind, I would just like to point out, and I've reflected on this a lot, is that, I'm a huge fan of the UN system. That's why I organized the Science Summit, of course. But bear in mind that the United Nations is not a legislature, nor is it a regulator. So I think this is hugely important, and I think this points to maybe, depending on the time of day or your mood, is that opportunity or problem, because we live in a very, very fragmented world when it comes to policymaking and when it comes to regulation. I think this community really needs to have a very, not necessarily comprehensive, but maybe cohesive approach to advancing that. And again, these are longer conversations. I realize that, so sorry I'm just trying to be brief. The other point is with regard to AI and regulation, and of course, up until about now, the poster child for regulation has been the GDPR, but now that's been usurped by the European Union's attempt at an AI regulation. Now, there's many aspects to this which are hugely important, but the one I'm pointing to is we're here at the UN and we're talking a lot about inclusion in its various forms, and of course, a lot of people think inclusion is having very nice people from different backgrounds in the room, and of course that is inclusion. I think that's demonstrable inclusion. But for me, inclusion means access to data. And if this pending regulation and potentially regulations followed by those from the United Nations, the UK and elsewhere, which all come with this wonderful initiative called extraterritorial applicability, and this means that effectively a small group of developed nations are regulating the rest of the world. And a motto I'm promoting is no regulation without representation. And I'm absolutely persuaded that if these regulations go ahead without an inclusive approach, then we are looking at a term, and there's literature on this, data imperialism. Many of the issues we're dealing with this week include lots of discussions around decolonization. And I'm very on board with that. But I'm also explaining to people that, in fact, in the area of data, we are looking at least recolonization, if not imperialism. And this is happening. And this community needs, in my view, to be very much on board with understanding that as a process and reacting to it. And part of what we're doing this week is trying to develop, or these weeks, is develop what I'm loosely calling a voice from Africa on this issue, because right now, African nations have no say in this regulation, which will apply directly to them. This is bad in so many ways that I think it really needs to be understood by this community and others. So thank you very much, Frédéric. Thank you.
Yeah.
So I guess that the reception has started downstairs. So we actually are about to get our much-deserved drinks. But maybe on those words, I don't know if there are any comments, or Magali or Mahmoud, if you wanted to apart from the round of applause and echoing what Declan was saying.
I just want to say thank you. Thank you so much for what you said. I think this is so important. Sometimes when we speak, I think it's often seen as we speak because we are the ones either underrepresented or we are speaking for our communities. But when other people who are not part of the community talk on behalf of us, I think that sends a powerful message. So thank you very much.
I fully agree. And I will say also that at the World Health Summit next month in Berlin, this is a topic of one of the discussions on one of the panels, which I happen to be on. So I would love to discuss that further with you, and we can take that message forward. Thank you.
And on that note, I would like to conclude this event by thanking all of you for being here, thanking all of the co-organizers of today and also our supporters and funders of this very interesting and compelling occasion that we had to feed into those discussions. As you just heard, there are many issues being discussed currently in the UN setting, but also in the future, as I mentioned. And we wanted to conclude today with a call to action that we wanted to share with all of you, that we were thinking could summarize in the best way everything that was mentioned, but obviously could hardly be exhaustive given the gamut of the different issues, the different topics that were touched upon. Of course, it's not going to solve all of them, but if it can move the needle in the right direction and serve the interest of the collection of organizations, of people in this room, but also of the community that you do serve and represent, that's exactly where we believe we would have met the objective of today. And we hope to be able to continue this discussion onwards and not wait for another year to to go before seeing all of you. So we'd like to stay in touch. We'd like to continue that dialogue. And as I mentioned, as EBC, we've got this commitment and we've got this opportunity to do so. So I certainly would like to give you rendezvous very soon in this continued dialogue. So thank you very much and enjoy the reception.